Buenas tardes, ¿cómo están ustedes? Bueno, este es un día muy especial para nosotros, para el cierre de la semana de los errores innatos de la inmunidad. Tenemos el placer de tener un webinar excelente con participación de profesores internacionales que están dando lo mejor de ellos y sobre todo lo mejor en este momento con la diferencia horaria. La verdad que esta pandemia ha hecho que todo el mundo tenga muy buena voluntad para poder participar, a lo cual tenemos nuevamente que agradecerles. Y vamos a seguir presentando todo lo que hemos hecho en este momento, es decir, lo principal es gracias por estar ustedes ahora. Y todo lo que hemos hecho en estos meses, por favor, que es las actividades del LASID. Ustedes saben que sigue nuestro curso de citometría para el diagnóstico de las inmunodeficiencias primarias, a cargo de la doctora María Isabel Gallar, el diagnóstico genético en el síndrome de errores innatos de la inmunidad, que no se lo pierdan, dictado por la doctora Cecilia Poli, la clasificación de los errores innatos de la inmunidad, Ekaterine Godoris y Alejandra King, que va a estar muy rápido en nuestras redes, y por supuesto nuestro simposio de actual, que no dudo que va a ser algo sumamente importante para toda la comunidad de la CID. Por favor, la próxima. Sí, la próxima. Sabemos que la importancia de todos estos eventos, nosotros lamentablemente necesitamos contar de todos ustedes, por lo cual la virtualidad va a ser el eje en este año nuevamente. Alfonso, ¿podrás presentar la imagen del Congreso? Nosotros los esperamos en nuestro LASID 2021. Hemos tenido el honor de invitar a muchos de ustedes que esperemos y sabemos que va a ser exitoso, pero lamentablemente tendrá que ser en forma digital. Esperamos muy pronto, 2022 y 2023, poder nuevamente estar unidos. La próxima, por favor. Siempre vamos a insistir en la importancia del registro. Nuestro registro LASID es una forma de presentación de nuestra sociedad y de conocer la realidad de las inmunodeficiencias, de los errores innatos de la inmunidad en nuestra región. También tenemos, acuérdense, el registro actual de pacientes que han tenido COVID. Es sumamente importante saber la realidad de los pacientes en la región. Y sí, volvemos a invitarlos, la próxima por favor, a que se asocien. Nuestra sociedad necesita de todos nuestros miembros y nuestros jóvenes médicos y no tan jóvenes, pero que necesitamos seguir trabajando en conjunto y crecer porque realmente las inmunodeficiencias existen, necesitamos diagnósticos tempranos, necesitamos el desarrollo de laboratorios tempranos que ahora vamos a ver en las diferentes presentaciones de hoy, la importancia del diagnóstico en los pacientes. Así que bueno, ahora para no robar tiempo, vuelvo a presentarles este meeting. Tengo el honor de presentar y realmente me siento sumamente contenta de poder compartir con la comunidad LASID un tema que no sea COVID. Es decir, COVID nos ha tomado a todos y nos sigue tomando y nos seguirá tomando en este momento a toda la comunidad científica, médicos clínicos del mundo. La realidad que tenemos que agradecer sobre todo al doctor Ignacio Uriarte, que en un ratito lo voy a presentar, porque no solamente es un excelente profesional, sino que ha llevado a cabo y ha coordinado durante este tiempo todo lo que ustedes van a ver. Así que todo LASID y en mi nombre, muchísimas gracias, doctor Uriarte. Y la verdad, que como les dije, la buena voluntad de nuestros colegas que han tenido para presentar, y porque son amigos de LASID, muchos de ellos, han estado acá. Sin ellos no hubiese sido posible, así que mil gracias, Gracias por estar, Chip, Marco, Isabelle, Amanda, Leonardo y todas las personas que van a participar, por lo cual muchísimas gracias desde el corazón de LASID. Y ahora sí voy a presentar al doctor Ignacio Uriarte. Él es inmunólogo pediatra, jefe del área de diagnóstico y tratamiento de enfermedades inmunológicas del Hospital Materno Infantil de Mar del Plata. Es profesor titular de la Cátedra de Agentes y Mecanismos de Defensa y Nutrición de la Escuela Superior de Medicina de la Universidad Nacional de Mar del Plata. Él me dijo que dijera que ama el surf, que es un amante del surf y que tiene 2 hijos hermosos. Y yo agrego, es un gran amigo. Así que, bueno, toda tuya la presentación y ahora nos vamos a deleitar con este simposio. Nuevamente, muchas gracias. Ignacio.
Bueno, muchas gracias a todos por la invitación. Muchas gracias, Liliana, LASID, por este momento. La verdad que esto hola, ¿cómo les va? Muchas gracias. Ha sido muy interesante para nosotros empezar a compartir y unir todo esto a raíz de, como siempre, pacientes que nos hacen estudiar un poco más y pensar. Hemos tenido la posibilidad de conocer estos magníficos profesionales que tenemos hoy aquí con nosotros como invitados, no solamente profesionales, porque tenemos gente, como verán, como la doctora Mietz, el doctor Gatorno y Amanda Umbrello y al doctor Leonardo Oliveira, sino también a Chip Chambers, que es nuestro primer expositor, que le doy una gran cordial bienvenida. Chip es un amigo, es el presidente y el fundador y director de la Fundación DADA2, es padre de 2 hijos con DADA2, con deficiencia de adenosina 2, y a raíz de charlas hemos tenido la posibilidad de, a través de Chip Chambers y de la Fundación, de haber participado de los consensos mundiales de DADA2. Hemos tenido la posibilidad de revisar un poco la historia de DADA2 y la literatura, y siempre nos sorprendió que en estos últimos 6 años, desde que se diagnosticó por primera vez la enfermedad hasta aquí, no teníamos diagnósticos de otros pacientes más de los que habíamos diagnosticado allá hace un tiempo en Mar del Plata, donde yo vivo, y por eso avanzamos en esto para ver y para profundizar la difusión de la enfermedad, que creemos que debe haber seguramente algún otro paciente que debe estar ahí por ser diagnosticado, alguna otra familia, y para generar una red de contactos y de posibilidades diagnósticas y terapéuticas, como van a ver, como han resultado para mis pacientes por lo menos, que son puertas que siempre están abiertas y con gran disposición. Sin ir más lejos, Chip además es médico, es miembro de la Advisory Council de Tennessee para enfermedades raras, y ha sido el jefe de cirugía endocrinológica del Hospital de la Universidad de Vanderbilt en Nashville, Tennessee. Muchas gracias, Chip. Va a ser nuestro coanfitrión, Chip Chambers, hoy. Y sería, ahí nos están avisando de que no vemos bien la pantalla, Alfonso, ahí está. Chip, te damos la bienvenida, te agradecemos mucho la participación y tu tremenda generosidad y cariño y dedicación que le pones a difundir, crear y profundizar el diagnóstico, tratamiento y contención, no solamente de las familias y los pacientes, sino también de los médicos. Muchas gracias, Chip.
Good morning, afternoon, or evening, depending on where you're hailing from today. My name is Dr. Chip Chambers, and I'm the former Chief of Endocrine Surgery at Vanderbilt University Medical Center in Nashville, Tennessee in the USA. I still hold my assistant clinical professorship there. More importantly, I'm the father of Allie and Trey Chambers, both who carry a diagnosis of deficiency of adenosine deaminase 2. I'm the founder and president also of the DADA2 Foundation. I really want to thank Ignacio for pulling this group together to talk about DADA2. I guarantee you there will be patients that you will see after this conference where you will think about the diagnosis of DADA2 and more than likely diagnose some DADA2 patients. Ignacio has been there with me from the beginning, and I can't thank him enough for all the collaboration that he's provided over the years. I also want to thank the LAIDS for their support in pulling this meeting together. Now, I'm not going to talk about the diagnosis and treatment and research into DADA2, although I love talking about those things. Ignacio has put together an unbelievable panel to do that. Almost all of these doctors, all of them actually, work in consort with the DADA2 Foundation as we all work to find a cure for the disease and improve the lives of these patients. What I want to talk about instead is the lessons we've learned as the DADA2 Foundation on collaborating with you, the physician and scientist, in order to accelerate that pace of discovery of new treatments and really improve the lives of these patients around the globe. Good morning, afternoon, or evening, depending on where you're held. Now, I think as doctors, all of us have maybe heard this statement one time or another. If you're a physician, you definitely don't want to have a case report in your family. Unfortunately, as you just heard, I have two. And so that's made me develop this mantra that I really think solidifies the thinking around rare diseases. It's only rare until someone you love has it. And I think that's a driving force that we all could remember as we go forward in understanding rare diseases. To the patients and to the families, it's not rare. It's very personal, and they're there and willing to get involved and help and solve the questions that come up. So we really began this journey with really two simple principles or goals or missions of the DADA2 Foundation. One, that was to find a cure for DADA2, and two, improve the lives of those patients. But there are many other rare diseases out there. You may or may not be aware there are, as of today, about 8,500 rare diseases out there, and about 50% of those affect children. But the most damning statistic that I'm aware of is that there's treatment for less than 5% of those patients. And to me, that's just unacceptable as a doctor. You know, as the pace of genetic testing has massively increased around the world and the price has massively decreased, you know, you can get a primary immunodeficiency panel from Invitae for $250 US, and DADA2 happens to be on that panel. So we're diagnosing and finding more and more rare diseases. I think we'll even find the genetic basis of more common diseases. But we've got to accelerate the pace of discovery of treatments. The best example I can think of this is sickle cell anemia, where we've known the genetic defect for 35 or 40 years, but it's only now we begin to talk about gene therapy and other ways of actually curing the disease. So I told you about my kids, and so I want to tell you a little bit of my own personal story with DADA2. So my daughter Allie is now 24 years old, and my son Trey is 17. But this story starts when Allie was only 2 years old, and we were out in the backyard one day in a hot summer day, spraying water on her, and we noticed that her legs sort of developed a lacy purple hueish rash. And shortly after that, we also noticed some small, probably 2 millimeter subcutaneous nodules on her legs that were very painful to touch. So what would we do? Well, we took her to a pediatric dermatologist who was a friend of mine, and he looked at these and he said, well, Chip, I think these are flea bites. And I said, David, the only problem with that is we don't have a dog and we don't let her go out a lot, so I don't think that's in the differential. So that led to a biopsy, which showed a small to medium vessel leukoclastic vasculitis, but also to some pathologist's eye, there was concern about lymphocytes surrounding those vessels. And so that led to a 4-month journey to try to exclude T-cell lymphoma. So once it was finally excluded, the question was, what's the diagnosis? So we sought opinions sort of across the country, and we arrived on the diagnosis of cutaneous polyarteritis nodosa, or CPAN. Many folks wanted to put Allie on steroids, but at 4 years old at that point, I just couldn't see doing that long term. So we lucked upon the drug dapsone. You'll be familiar with that drug probably, as it's been used to treat leprosy over the years. And sure enough, that drug actually improved the nodules. They would go away, but about every 2.5 years they would recur. And so we'd simply increase the dose of the dapsone and they would go away again. However, when she got to about 15 years of age, other abnormalities started showing up. For example, increased liver function test, decreased platelet count, decreased absolute neutrophil count in the 200 and 300 range, profound fatigue such that she missed her entire senior year of high school but was proctored on her exams at home and still finished. And we had sort of tapped out on our thoughts at Vanderbilt. So at that point, we went to the Mayo Clinic to see Ann Reed, who was chairman of pediatrics there and chief of rheumatology, and Dr. Larry Gibson, who was a dermatologist with some expertise in CPAN. And to make that story short, essentially they didn't know what was wrong with them, but they kept looking and they kept pursuing. And we did figure out that she had primary immune deficiency. So we began her on gamma globulin, hoping that it would affect the vasculitis, but it did not. And Allie began to get sicker and sicker. Those liver functions became more abnormal, almost to the point that we were actually flying around the U.S. actually talking to people about a bone marrow transplant, even though we didn't know exactly what was wrong with her. And then in 2013, my son popped up with a nodule. Now, even though I didn't think it looked like a CPAN nodule, and I was pretty much an expert on them at that point, we flew up to Mayo and biopsied, and late that night after the biopsy, Larry Gibson, the dermatologist, called me to tell me that indeed it was a leucoclastic vasculitis in the skin. Now, all of us really couldn't believe that, but we quickly decided that we were going to do whole exomic sequencing, despite the fact that the Mayo Genetics Board didn't recommend it. But we did it anyway, and we sent that to Baylor University in Houston, Texas. And then Roshni Abraham, that many of you may be familiar with through the Clinical Immunology Society, was head of the immunology lab at the Mayo Clinic at the time. And so she posted the children's case on the Clinical Immunology Society listserver. And a chap from Finland responded, Mikko Sipanen, and said, I think you ought to check these kids for deficiency of adenosine deaminase 2. Now, mind you, there are no published articles in the literature describing such a disease. So when we asked him about the phenotype, what he said was, well, these children can have strokes. And we said, hold on. You know, these children have not had strokes, so we don't think that that's the diagnosis. He said, I think you ought to entertain it. And we said, well, how could we diagnose it? And he said, well, send some blood to me in Finland and I'll run an ADA2 enzyme level. So we packed up blood and then sent it to Finland. And then an amazing compilation of events actually occurred. In February of 14, in the New England Journal of Medicine, Dr. Dan Kastner at the NIH and Penina Elkins in Jerusalem simultaneously published an article describing deficiency of adenosine deaminase 2 for the first time. Almost at that exact same time, those enzyme levels came back from Finland, undetectable in my children and half normal in my wife and I. The genetic sequencing was not back, so we called Baylor and said, quit looking in 1% of the genome and look at this gene, and boom, we had the diagnosis. And it just goes to show you for rare diseases how it can take a multi-institutional, multi-international approach to really get a diagnosis. And we'll talk more about that in a moment. Now, there's a lot of great organizations out there doing things for rare diseases. For example, the National Organization of Rare Disease in the US, NORAD, Eurotas in Europe, the Rare Disease Research Network at the NIH. But we're very fortunate to be part of an initiative called the Chan Zuckerberg Initiative. And yes, Zuckerberg is Mark Zuckerberg of Facebook fame. His wife, Priscilla Chan, is a pediatrician, and in 2020 they established a grant program and call it the Rare as One Initiative. And we were one of 30 patient-led rare disease foundations to receive that grant to really build the infrastructure of the foundation. But what has been so amazing about this journey is the interaction between the rare disease foundations themselves. They're in all stages of development, some with years of experience, some with few years of experience, and it's a great way to network and really understand processes that are very complex, but that by sharing, you can implement in a very short period of time. And we're honored and pleased to be a part of this Rare as One initiative. So, our motivation is pretty clear, right? It's to shorten that time between disease discovery and diagnosis. It's also to get the patients involved early in the disease process discovery so that they can help drive things forward towards solutions. And the end result is what we know. It's to improve the quality of health of these children and adults with rare diseases, and in particular DADA2. So patient collaboration involved in this process is something that's relatively new. I know that I have a lot of gray hair, and we certainly, while we listen to our patients in the exam room, we certainly didn't include them in extensive discussions about a new disease or how to treat a disease, etc. But now it's become quite commonplace. The old approach was there was a disease that was discovered. We would shepherd our data until we're ready to publish our data, and that could be quite some time, if not years. We then published the data and we presented a year or two later at a meeting. Someone comes up to us after the meeting and says, I've been interested in this disease or this particular pathway. I'd love to collaborate. And then what happens? Literally, life gets in the way. We're all people. We all have many things going on. And while the idea at the moment is excellent, it just sort of falls off because there's so many things to do. Now, if we looked at that a little bit differently, though, and we looked at disease discovery, and we engaged the patients early on in this process, and if the process looked more web-like than linear, I think things could happen a lot faster, and that's what we've shown in the DADA2 Foundation. The foundation is established, patient registries can follow, fundraising, grant funding support, being a vehicle to allow conversation among the scientists working on mechanisms, more publications come about, more presentations come about. And as you've already heard me say in my own particular case, and as we've seen with COVID, with technology today, the world is much closer together as opposed to being more far apart. And I think in medicine, we've not utilized that approach to its maximum effectiveness until just recently with COVID. Now, rare disease patient groups can do a whole lot of things. And, the DADA2 Foundation, we've shown that these things can be effective by connecting patients to their specialist, for example. What specialist do you need to see? Is it a rheumatologist? Is it a hematologist, oncologist? Linking the scientific community at our conferences that I'll talk about in a minute. It's really amazing to hear the scientists and the physicians get up and speak, and all the commonalities they come upon or come upon things that they think need to be solved in trying to define research agendas. The infrastructure of the foundations are very important because they can help start registries early. They can start natural history studies early, and they often can raise the funding to do that. And they also can get support from the community and ideas from the patient community. As doctors, we may think we know the things we need to be studying that are affecting the patients, but until we hear the patients say it, we really may not. Now, in the US, advocacy for rare disease is a huge, huge thing, and both a national level at Congress as well as locally within states. I just recently was named to the Rare Disease Advisory Council for the state of Tennessee, and that was an appointment by the governor. And we're trying to formulate how we in Tennessee are going to attack rare disease in our locale. And then finally, fundraising and grant making. It's essential to run these enterprises and to run these efforts. One has to have capital, and there are definite ways that can do it, many of which we've learned from the Rare as One cohort. So the DADA2 story, I've already told you a little bit of my own personal story, but the DADA2 Foundation was formed in 2016, and we held the inaugural international conference on the disease less than 2 years after the disease discovery in 2014. Now, the best we know, and by looking into the literature, that's the soonest after a disease discovery that a meeting of that scale has ever been held. To date, we've had 3 international meetings. The most recent was in November of 2020, which was all virtual due to COVID. But what we had were 500 attendees from 39 countries. Absolutely amazing. We're continuing to grow the patient community. And in fact, we're going to be holding a patient and family conference on May 14th or 15th of this year. And if any of you have DADA2 patients, at the end, I'll show you my email. We would love to have them attend. And so we'll have translators available. And so you can just email me or put me in touch with the individual if they want to attend. There are a lot of international medical centers involved in DADA2. The NIH is only one. I've already mentioned NORAD and Eurotas, but literally all the major medical centers throughout Europe, the Middle East, China, Japan, have been involved in studying and researching DADA2. We also got an ICD-9 code in the fastest time ever for a rare disease, which ties then in the US, it ties the billing data specifically to DADA2, so you can search that database and find the diagnosis. Coming off the heels of the November 20 conference, we've got some ambitious goals. We are currently working on a consensus paper, and we have a group that's formed doing that. We are ready to launch a patient registry and natural history study. You know, when you start studying rare disease and you request the charts on patients, they're not just a few pages long. They're 2,000 to 5,000 pages, and that in and of itself is a natural history study, just capturing that data on that patient and then the next and the next. We're launching a collaborative platform to allow the scientific community to continue to collaborate real time in between conferences. And we are continuing to raise money and have a very organized plan. We were very fortunate to receive a $200,000 grant in US dollars just recently from a grandmother of a little girl with DADA2. Now, what if we don't do these kind of things? You know, what's the cost? Well, in the US alone, there are 30 million patients with rare disease, about 4 million globally. And as I said, treatment for less than 5%. So that results in a lot of misdiagnoses, a lot of unnecessary or even dangerous treatment. It can lead to severe debt where the families are trying to cover these medical costs. I've seen families literally sell their home, to pay for medical care for their child. And not to mention the stress and isolation, which is real. We felt that in the Chambers family for sure. And it takes too long to diagnose the diseases, as we've mentioned, 5 to 7 years. That needs to be much shorter. As a thyroid surgeon, it doesn't take me 5 to 7 years to diagnose a papillary thyroid cancer. I usually can do it in one clinic visit. And then the premature death rate is just unacceptable from these rare diseases, as high as 50%. I think we would all agree that a mortality rate that high is also unacceptable. So the first steps to patient collaboration, I've got some questions I want to leave with you. We already said a minute ago there are 30 million Americans with a rare disease, so I'll use that as the bar. So who is your 1 in a 30 million patient out there who has unusual presentation, unusual symptoms? Who is that patient, or who is that patient that walks in your door tomorrow into your office? And then once you see that patient, what's the next question you're going to ask? Are you going to just assume the patient has Munchausen because they don't fit in a diagnostic box? Or are you going to ask questions outside of the box and try to see, could this be one of the 7,000 to 8,000 rare diseases, or could this even be a new rare disease? And finally, how can we get the patients involved early on in this work? Because I guarantee you, you'll find no greater supporters, no greater advocates, no greater people willing to help than the family and the patients with rare disease. They are engaged in their medical care, which is what we've always said we wanted from our patients. And this particular patient group is majorly involved and wants to do nothing but help you, the clinician and the scientist. So again, I want to thank Ignacio and the LAIDS for this time today and for the magnificent talks you're going to hear in just a few minutes. Please, anyone wants to collaborate or talk to me, you can get me at chip.chambers@dada2.org. I literally talk with physicians and patients all over the world. I spoke to a doctor in Libya and Algeria just this last week. If you're not on our mailing list where you can be updated about conferences, just send me an email and say that you would like to be. And we'll make sure you're on our list for the invitee list for future meetings and conferences. And again, if you have a DADA2 patient, we are having a conference just a few weeks from now, May 14th and 15th. If they'd like to attend, you can either give them my email or you can email me, and we'd love to have them attend. Thank you very much for this opportunity, and I look forward to the rest of the presentations.
Bueno, espectacular, Chip. Muchísimas gracias. La idea es increíble, increíble el trabajo desde con tan poco tiempo, como bien se dijo ahí, de creación de una fundación para una enfermedad tan particular. La última vez, no sé si lo tengo ahí con audio, Chip, para que comente, o con video. En el primer consenso mundial se hizo y éramos no tantos países participantes, y en el último consenso, ahora mundial, que fue el año pasado, que se hizo por vía web, una cantidad impresionante de profesionales, de médicos de todos lados, y no solamente de médicos de todos lados, sino también de pacientes que han participado desde diferentes lugares, que fue una cosa impresionante. Chip, I don't know, the last meeting, the last online meeting, the consensus, the worldwide consensus in the 2020, do you remember how many countries have participated?
Yeah, in the November conference, which was the third international conference, we had 500 plus doctors from 39 countries. And it simply amazed me. In the 2018 conference, we had 123 doctors and scientists from 25 countries. So look at the jump between 18 and 20. And we had about 93 patients and families from 25 countries at the 18 meeting. And unfortunately, we couldn't hold the scientific meeting, the patient meeting together virtually because it was too complex. But we are about ready to hold a patient meeting, and Dr. Umbrello speaking at that meeting. And we're looking really forward to engaging the patients.
Now, incredible. Chip, he is invited to co-host with us. So we are very glad to have you here and have you on. And it was incredible for us because it's important to share about how it's important how it's the need that a foundation supporting not only the patients and also the net needed to diagnose and treat these kind of patients. And this is possible, it's easy, and completely free for the patients and the physicians. So thank you very much, Chip. And we are going to get through the next speaker. He's the Leonardo Oliveira. Leonardo is an immunologist and allergist, es un inmunólogo alergista, es from Brazil, from São Paulo. Es el jefe del Centro de Inmunología y Enfermedades Raras del Hospital 9 de Julio y el jefe de enfermedades autoinflamatorias del consultorio del seguimiento ambulatorio de enfermedades autoinflamatorias del Hospital de Clínicas de la Universidad de San Pablo. Con Leonardo nos hemos conocido hace un tiempo ya, siempre dentro del área de los síndromes autoinflamatorios. Se ha formado además con Marco Gatorno, ha trabajado en Europa. Le damos la gran bienvenida y muchísimas gracias, Leonardo, por participar.
Thank you very much. Again, I'm going to present now the second clinical case at the DADA2 in Latin America by the Latino-American Society for Primary Immunodeficiency. And again, I'm Leonardo Mendonça. This case now is observed at our University of São Paulo, the University of São Paulo, and where I'm part of the ambulatory for autoinflammatory disorders. I have nothing to declare. And this case now is a 14 years old male. He was born and raised in São Paulo. He also was born from non-consanguineous parents. He also had a healthy brother. And at the age of 3 years, he had a progressive enlargement of a cervical lymph node. A biopsy confirmed Hodgkin lymphoma at that time. He was treated with chemo and radiotherapy. And he is disease-free since 2010. But since the age of 8 years, he has recurrent episodes of fever, always associated with severe abdominal pain that requested hospitalization for many times without diagnosis. During the course of the fever, he has a cyclic pattern of elevation on acute rectal markers. And neutropenia also is a consistent finding, and very high levels of lymphocytes is also a consistent finding during all these episodes. He had many episodes diagnosed of mesenteric adenitis, and sometimes related to infections, sometimes related to non-infective episodes. It's not clear all the diagnosis of the clinical picture before he came to us. But at the age of 9 years, he had a presumptive diagnosis of an ALPS syndrome. He received 3 cycles of rituximab. He had the resolution of the symptoms while on rituximab, but short after the rituximab was discontinued, 6 months after, he had another episode of fever, and it was not effective in controlling the disease. At the age of 10, he had a huge splenomegaly, and due to the abdominal discomfort he had with the organ enlargement, he was submitted to a splenectomy, but it didn't change anything in the clinical picture. So at that time, at the age of 10, he was sent to our department for the evaluation for an inborn error of immunity. And we also kept the diagnosis of ALPS-like syndrome. We put him on mycophenolate, but he had another flare right after he started the mycophenolate, also with a severe neutropenia. So we discontinued mycophenolate at that time. Here we can see some lab analysis. He had mild anemia, high levels of platelets too, very high levels of lymphocytes. Unfortunately, I have not mentioned here the neutrophil levels. Very high levels of CRP on some episodes not with high levels of CRP, but always positive levels of inflammation. And we also can see he had hypogammaglobulinemia that we don't know if it was secondary to the treatment he received or if it's related to the disease, but we also can see he has considerable but not very high levels of double negative T cells, both on T and CD3 groups. And he had another severe flare with fever, abdominal pain, high levels of acute reactant markers again. We performed a colonoscopy at that time, and we could see a colonic inflammation, and the pathology was not definitive if it was inflammatory bowel disease or not. We suppose that it was due to herpes virus infection. We put him on acyclovir, and it was not effective, but could partially control the symptoms, but at the end we decided to put him on very high doses of steroids, and it was very effective in controlling both fever and abdominal pain. And steroids at that time could be slowly tapered, and we kept him for a while without flares. But when he achieved the dose of 20 milligrams per day of steroid, we saw another flare with the same pattern. At that time, he had also, additionally with the abdominal pain and the fever, he had a severe oral ulceration that evaluated to the loss of 2 teeth. And the pathology analysis, the first pathology analysis, supposed that it was a cancer, but we revised the pathology. It was just necrosis. We could not have a clear diagnosis of that. We performed again another colonoscopy that confirmed that he had inflammatory bowel disease. We put him on azathioprine, and we could taper the doses of steroids. And since then, he doesn't have any other flare of febrile flare. Another flare. This is the mouth when he had this flare that's very severe. We can see ulcer, very huge ulcer in the mouth, but it was not confirmed. There is no etiological confirmation of that. So we performed the genetic sequence of this patient, and we found a new mutation on DADA2 gene, a homozygous mutation on DADA2 gene, and we are also performing now the genetic sequencing for the family, and we had the same suspicion that maybe the healthy brother can be homozygous. So we also have that anxiety from our side and also from the family what to do with the healthy brother if he is also homozygous to the same mutation. Thank you very much again. Thank you for all those who works at the Center for Rare and Immunological Disorders at the Hospital 9 de Julio and at the University of São Paulo, especially again to all of our residents, the patients and the family. Thank you very much.
Bueno, muchísimas gracias, Leonardo. Leonardo es un caso súper interesante. Él también va a presentar el caso clínico número 2, que también resulta ser súper interesante y que nos da la posibilidad de pensar en otros diagnósticos diferenciales que son importantes a la hora de considerar las múltiples facetas de esta enfermedad. Cuando quieras, Alfonso, y estés en posibilidad, bienvenido.
Hi, my name is Leonardo. Thank you very much for NASA for inviting me for the DADA2 in Latin America. Thank you for the Latino-American Society for this initiative to talk about DADA2. And I'm going to present one case, the first case of DADA2 in Brazil. It was observed with a patient from the group of rare immunological disorders at the Hospital 9 de Julio, where I'm the head of the department. So, and I have nothing to declare related to this presentation. So the first case is a child, a 2-year-old female child. She was born and raised in the north of Minas Gerais from non-consanguineous parents. She also had one healthy brother. And the history started at the 6th month of life with recurrent fever. And with some of these febrile episodes could be noted skin rash, and undefined skin rash. And during all these febrile episodes, the family went to the emergency department, and she was diagnosed with flu-like disease. They treated her as just with flu symptomatic treatments for flu, and she was discharged, and nothing happened at that time. At the age of 2 years, however, the fever started to be persistent, and she was admitted to the hospital of Santa Casa of Montes Claros, Minas Gerais. She also had, at that time, diffuse verticular endothelial enlargement with diffuse lymph node enlargement and hepatosplenomegaly. Could also be observed during the course of her hospitalization. Anemia was a persistent finding with high levels of ferritin. Also could be observed very high levels of acute reactant markers. And all the investigations to rule out infectious and neoplastic case was done, and all came out negative. This is the picture of the rash that the family could observe during the febrile episodes, which is very inspecific, non-specific. It's not related to anything. Could not see that it's vasculitis, neither anything else. And this is the first laboratory analysis during her first admission. On her first flare that she was admitted, we could observe, we can see the anemia, we can see high levels of acute reactant markers, our DHL level mildly elevated too, normal levels of ferritin at that time, and all the antibodies was also negative. And we can also see a very high level, or not very high at the time, but high level of IgG with normal levels of IgA and IgM. On the second hospitalization, still on the age of 2 years, she had a sudden episode of low level of consciousness. ACT demonstrated an hemorrhagic stroke. They performed the non-geography and no vascular malformation, neither signs of vasculitis could be observed. There was a deterioration on her clinical picture. And at that time, we could clearly see a persistence of high levels of acute reactant markers, ferritin. And they contacted me at that time, and we suspected that it could be an inborn error of immunity, clearly in DADA2. So we started high dose of steroids that was not effective. We put her on cyclophosphamide that was also not effective. This is the MRI performed at that time. We can see ventriculoperitoneal derivation there, and we can see some signs of hemorrhage, of blood all over the brain. So still at that hospitalization, she had a second episode of hemorrhagic stroke, another angiography, no signs of vasculitis again. She had a very deterioration. She deteriorated on her clinical picture. She was very bad at that time. We put her on high levels of IVIG. It could not control anything, neither inflammation, neither the fever. And here we can see some laboratory analysis at that time. We can see now the anemia was a constant finding, high levels of acute reactant markers. She had very high levels of IgG at the end, and very high levels of ferritin too, and always negative to all antibodies. And this is her at the age of 2 before the second stroke. And unfortunately, after the second stroke, she died, unfortunately. And between the first and the second, we requested the genetic analysis, and the results just came after she had died. The genetic analysis came after postmortem. We found a pathogenic variation, a mutation on DADA2 gene, already described, already reported. And we are now performing the Sanger sequencing for all the family. And the main question now is that if the healthy brother also carries the same mutation, what should we do if we have to treat him, if we have to put something on to avoid the installation of the same disease. And this is the first case I'm going to present. Thank you very much. I would like to thank also for all those who collaborate for the centers at the Center for Rare and Immunological Disorders, and also in the University of São Paulo, especially for all the residents, for the patients, and for the families that trust in us, their cares. Thank you very much.
Increíble, espectacular. Muchísimas gracias, Leonardo. Ha sido una presentación de dos casos sumamente importantes y significativos, sobre todo por la variabilidad de presentación clínica que es típico de esta forma de presentación en DADA2. Agradecemos muchísimo, y sin ir más lejos voy a presentar mi caso, que son dos hermanos, como vamos a ver ahora, pertenecientes a una familia un poco más grande con muchísimos antecedentes que vale la pena destacar. Bueno, muchísimas gracias por la oportunidad de compartir y presentar tanto para nosotros, que presentamos casos clínicos, como para los expositores que han compartido y van a compartir con nosotros este maravilloso encuentro. Yo soy Ignacio Uriarte, soy médico pediatra inmunólogo de Mar del Plata, que es una ciudad que queda en la costa argentina, sobre el mar Atlántico, en la provincia de Buenos Aires, una ciudad muy linda que los invito a conocer y a visitar cuando puedan. Voy a presentar un caso de una familia que consulta su primera consulta es en el noviembre del 2012, cuando este niño tenía 14 años, venía con antecedentes de aftosis recurrente, con algunos antecedentes infecciosos de vía aérea superior, de inicio a los 8 años de edad, y a raíz de este episodio de aftosis recurrente, la pediatra le realiza un hemograma, y en los hemogramas empieza a observar neutropenia de características importantes, severas, y es derivado a la consulta en este contexto. El paciente tenía antecedentes de infecciones respiratorias leves, de comienzo en la segunda infancia, a los 8 años de edad, con requerimiento de internación por patología pediátrica banal, como síndrome febril, hiperangina, gastroenteritis, y una apendicitis con una complicación postquirúrgica, con un absceso de pared, que resolvieron favorablemente. Haciendo un resumen diagnóstico, la clasificación de aftas se puede orientar en base a su morfología, y puede haber aftas menores, mayores o herpetiformes, que pueden ser origen o que pueden guiar la conducta diagnóstica y terapéutica. En este caso, el paciente presentaba aftas mayores, con tamaño mayor a 1 centímetro, solían ser 1 o 2, de larga duración, con curación, en este caso en más de 4 semanas de duración, y frecuentemente con cicatriz residual. Como diagnósticos diferenciales de aftosis recurrente, tenemos aftosis solitarias, episodios recurrentes de 1 o más aftas que curan espontáneamente, que podríamos considerar a la enfermedad de Behçet y a otras patologías de tubo digestivo, y episodios únicos de aftas precedidas por vesículas que afectan múltiples localizaciones, que no era el caso del paciente, y aftosis oral persistente que afecta múltiples localizaciones con antecedentes particulares o compromiso. En este caso, el paciente presentaba antecedentes familiares de compromiso hematológico, y el paciente había sido evaluado con una neutropenia severa. En este caso, los diagnósticos diferenciales de neutropenia pueden involucrar trastornos hematológicos, infecciosos, inmunológicos y errores congénitos del metabolismo, como así algunas causas sintomáticas o idiopáticas o tóxicas por drogas. Yendo al antecedente familiar puntualmente y a la composición familiar de nuestro paciente, que es el paciente P1, que es Gabriel, presentaba el antecedente familiar de una hermana que a los 4 años de edad había presentado una anemia hemolítica autoinmune, que había sido rebelde al tratamiento con corticoides, con antecedentes de infecciones supuradas e infecciones respiratorias complicadas, importantes, y una vasculitis a los 2 años de edad que había sido diagnosticada como una púrpura de John-Lane-Henoch. Se realizó una interconsulta inmunológica en el año 1998, cuando la paciente tenía 4 años, 5 años, donde se diagnostica en base a los antecedentes un fenotipo compatible con inmunodeficiencia común variable, por lo cual inicia tratamiento, el cual sostiene con dificultad y regular adherencia, y a los 7 años de edad hace un cuadro hematológico con diagnóstico de aplasia medular y pancitopenia, con una mala evolución, y fallece en el contexto de un diagnóstico por una infección de parvovirus a los 7 años de edad. Nuestro paciente, luego de la primera derivación, se realiza un estudio de laboratorio donde podemos ver que el paciente presentaba leucopenia con una neutropenia marcada, hipogamaglobulinemia poliisotípica, tenía muy bajos valores tanto de IgG como de IgA y IgM, con adecuados valores de albúmina y de proteínas totales, unas poblaciones linfocitarias donde se puede ver que había una alteración tanto relativa como absoluta en el compartimiento de los linfocitos T, con una disminución significativa de los linfocitos T CD4. Linfocitos B y NK impresionaban ser normales, pero en el análisis exhaustivo del compartimiento del linfocito B se puede observar un defecto de maduración del linfocito B comparado con la población de su edad. A raíz de esta linfopenia predominante, o esta linfopenia significativa en linfocitos TCD4, se realiza una proliferación linfocitaria que podemos ver a través de CFC, que tiene una proliferación linfocitaria normal. En resumen, tenemos un paciente con antecedentes familiares, con aftosis recurrente, que presenta leucopenia y neutropenia, hipogamaglobulinemia, linfopenia T-CD4 y algo de NK con inversión CD4-CD8 y alteración marcada de la población B. Se amplían estudios de laboratorio donde podemos ver que tiene serologías negativas para algunas infecciones y vacunación a la que había recibido el paciente. Hizo hemaglutinina, los anticuerpos naturales anti-alfa no presentaban un valor de corte aceptable. Tenía unas eritrosedimentación y PCR bajas, y en ese contexto, en el contexto de los antecedentes, la neutropenia y la aftosis, se le pide una PCR en sangre periférica para Epstein-Barr y citomegalovirus que resultaron negativas. Considerando la posibilidad de una enfermedad de un trastorno con una falla medular primaria, se realiza una punción aspiración de médula ósea con biopsia que informa hipoplasia mieloide con reticulina negativo y citometría sin aberraciones. En este contexto, el paciente, por los antecedentes, reúne criterios de sospecha de inmunodeficiencia común variable, lo mismo que su hermana, cumple criterios LASID, inicia tratamiento de sustitución con gamma-globulina endovenosa, hematología por una mala respuesta y por una evaluación hematológica inicial, decide iniciar tratamiento con factor estimulante de colonia granulocito macrófaga y sostiene valores de neutrófilos en cantidad aceptable, por la cantidad de linfocitos que tenía en sangre periférica que eran persistentemente bajos. Además el paciente se le suma tratamiento profiláctico con Bactrim, y por los antecedentes de infecciones herpéticas con aciclovir. Considerando entonces el antecedente familiar, vamos a estudiar a los hermanos. En este caso, su hermano Guillermo presentaba antecedentes de infecciones también respiratorias leves, había sido evaluado por una hepatitis secundaria a una infección que impresionaba ser medicamentosa por quinolonas. Tenía los antecedentes ambos hermanos con compromiso inmunohematológico. El laboratorio inicial del segundo hermano de Guillermo, que es nuestro paciente número 2, en ese momento tenía 21 años, y él presentaba valores de leucocitos normales en sangre periférica, a diferencia de su hermano, con valores normales segmentados de neutrófilos, pero una disminución relativa y absoluta de linfocitos totales, con una hipogamaglobulinemia también, con una ausencia de IgM en sangre periférica, con una alteración también leve en el compartimiento T, y un significativo defecto también de memoria del linfocito B. Hay una linfopenia global, no se observa inversión CD4-CD8 como se observaba en el hermano. A raíz de los antecedentes se completa evaluación también con memoria de activación del linfocito T en CD4 y CD8, que resulta ser normal, y también se hacen proliferaciones linfocitarias por CFCE, también para este hermano, para nuestro paciente número 2, que resultaron ser normales. Respecto se amplían estudios inmunológicos donde se ven que las serologías para el paciente, para algunas infecciones y vacunas que había recibido para antígenos proteicos, habían resultado negativas en más de una oportunidad. También las isohemaglutininas resultaron no observables, negativas. Él sí se pudo estudiar con una respuesta adecuada de neumococo post-estímulo, con 2 dosis de vacuna pneumo 23, logró generar respuestas intermedias, con una punción aspiración de médula ósea también que se hizo por el antecedente familiar y por los hallazgos encontrados, donde también se ve hipoplasia mieloide, reticulina negativo y sin aberraciones, autoanticuerpos negativos. En sangre periférica se complementa también con una PCR para Epstein-Barr y citomegalovirus que resultan ser negativas. No se observa en ningún momento eritrosedimentación o PCR elevadas, y en las imágenes se le pide una ecografía abdominal donde se observa una esplenomegalia homogénea y una tomografía tóraco-abdominal que informa también la esplenomegalia sin otras anormalidades. En este sentido, también nuestro paciente cumple con criterios ESID para inmunodeficiencia común variable e inicia tratamiento acorde a las normas. Entonces, considerando que tenemos 3 hijos de una misma familia con un diagnóstico de inmunodeficiencia común variable, con presentación predominantemente hematológica e infecciones, vale la pena considerar que es una inmunodeficiencia muy frecuente, que es una de las más frecuentes en todas las poblaciones. Algunos de los diagnósticos asocian una causa genética determinada. No suele haber para este tipo de inmunodeficiencia agregación familiar o casos familiares, y la neutropenia no suele ser una manifestación clínica frecuente en este tipo de inmunodeficiencia, en este tipo de forma de presentación clínica. Entonces, tuvimos la suerte en un congreso de tener la posibilidad de presentar al paciente al equipo del profesor Greenbacher en Alemania, y a través de los antecedentes familiares que reunía el paciente y su familia, donde había antecedentes familiares de inmunodeficiencia primaria. En este caso no había linfocitos B menores al 2%, pero sí características que nos permitían pensar en una agregación o una causa genética de la enfermedad. Se pudo realizar el estudio genético en Alemania, en la Universidad de Friburgo, a cargo del doctor Greenbacher. El resultado del estudio muestra que el paciente, nuestro paciente Gabriel, presentaba una mutación homocigota missense en el exón 2, con una sustitución en la posición 112, que confirma el diagnóstico, y a raíz de este estudio se se completa la evaluación con una evaluación funcional de la actividad de adenosíndiaminasa 2, que se pudo enviar al laboratorio del doctor Hirschfield, al que le agradecemos de sobremanera, donde se puede observar la ausencia de actividad relacionada a la enzima en el paciente. Su hermano, Guillermo, presenta una mutación en forma heterocigota compuesta, donde hay 2 sustituciones en la misma posición que presentaba su hermano de forma homocigota, y en otra posición, en R169, una sustitución en esa posición, que confirma también el diagnóstico en el caso del paciente, y la actividad enzimática que también se deriva al laboratorio del Dr. Hirschfield resulta ser ausente. Entonces se avanza con el estudio del fenotipo familiar. No podíamos estudiar a la hermana y no pudimos estudiar al padre porque había fallecido unos años antes, pero podemos ver que la madre es portadora para la variante en la posición 112, y su hermano, Santiago, que no tiene antecedentes y ambos tenían actividades enzimáticas normales, es portador en una wild type y una variante
en R169Q, lo cual inferimos que su padre muy posiblemente sea portador también en una variante en R169Q. Entonces la deficiencia de adenosíndeaminasa 2 puede manifestarse con un fenotipo clásico, como vamos a ver ahora más adelante, con un fenotipo con componente inflamatorio o no inflamatorio y un componente de un compromiso inmunohematológico, donde hay hipogamaglobulinemia, autoinmunidad, linfopenia, donde puede haber otras citopenias o compromiso hematológico puro. En este sentido, el paciente avanzó con citopenias persistentes, con compromiso progresivo del componente hematológico, predominantemente con una neutropenia y una anemia significativa, que requieren una revaloración por hematología, donde ya a los 2-3 años del diagnóstico se puede observar que el paciente ya presenta mielofibrosis y una gran pancitopenia con moderada y severa alteración del componente medular. Entonces, la deficiencia de adenosíndeaminasa 2 puede presentarse de diferentes formas fenotípicas que vamos a ver con posterioridad. Luego de los diferentes consensos que tuvimos la grata y fortuna de participar a raíz de la invitación de Chip Chambers, conocí a Chip Chambers y a través de su ayuda hemos podido ordenar y conseguir mejores propuestas terapéuticas. En este caso el paciente inicia tratamiento con factor de necrosis tumoral alfa, inicia visitas al Instituto Nacional de Salud del NIH en Estados Unidos, que nos ayudan con el tratamiento en ese momento, y a raíz de la evolución que presentaba desfavorable a pesar de el adecuado uso, en este caso de adalimumab, estaba con 40 miligramos cada 15 días, tuvimos que considerar otras posibilidades. Nosotros en nuestro centro tenemos este tipo de seguimiento que es multidisciplinario cada 4 meses, con laboratorios cada 6 meses e imágenes anuales, donde es evaluado por las especialidades que intervienen en esta patología. Se le hacen laboratorios con parámetros de inflamación y evaluación general, e imágenes anuales, resonancia del sistema nervioso central, ecoabdominal, angiografía, al menos una, y si tuvieron ACV de inicio o anual, se deben pedir al diagnóstico y en base a eso se adecúan las imágenes. Presentan algunos problemas, como dijimos, estos pacientes en su seguimiento, y en nuestro caso, el paciente presentaba mielofibrosis, por lo cual tuvimos que considerar la posibilidad de trasplante de médula ósea en el paciente. En ese momento no había ningún paciente trasplantado en nuestro país, por lo cual a través de la generosa participación de Chip Chambers y de la colaboración del NIH, pudimos derivar al paciente, y es un muy buen momento para comentar que las chicas lo recibieron de una forma fabulosa. Hemos podido colaborar y he podido participar del trasplante y del seguimiento allá en Estados Unidos. Ha sido Jennifer Canacry y Dimana Dimitrova, que nos han recibido allá junto con todo el equipo, con Amanda Umbrello, el doctor Kastner y todo su equipo de seguimiento de enfermedades reumáticas y vasculitis, lo cual nos ha podido generar una gran alegría, porque el paciente se recuperó, ha sido trasplantado de una forma, a pesar de que en su momento ha tenido gran complicación, muy satisfactorio. Hoy en día está muy bien, ha cruzado COVID-19 de una forma muy positiva, sin casi enfermedad. Así que voy a presentar a Jennifer Canacry y a Dimana Dimitrova, que van a hablar sobre puntualmente el trasplante en este paciente del Centro de Investigación en Cáncer del el centro del Instituto de Cáncer Nacional del NIH Estados Unidos. Muchísimas gracias y los dejo con las doctoras.
Mientras tanto, mientras Alfonso carga la presentación, Alfonso, dame un minuto. Después de esta presentación, donde terminan los casos clínicos, vamos a tener un momentito de alguna pregunta y respuesta. Vamos a necesitar que tengan a mano su celular o su equipo móvil. Les vamos a dar una dirección para que tipen y van a poner un número ahí, ahora les explico bien. Y la idea es generar una interacción para hacerlo esto un poco más divertido. Luego de eso va a haber 5 minutos, 10 de receso, para que cada uno haga lo que tenga o necesite hacer en ese tiempo, y cerramos con, con Alfonso le estamos pasando el link para que lo vayan viendo mientras se va cargando la presentación de las doctoras que hicieron el trasplante en NIH, y una vez que tengamos el receso, vamos a regresar con la presentación espectacular y muy esperadas de la doctora Mietz, el doctor Gatorno y la doctora Amanda Ombrello. Gracias, Alfonso, ya estamos.
Thank you for the opportunity to describe to you our experience with allogeneic hematopoietic cell transplantation for patients with deficiency of ADA2. Our first DADA2 patient was transplanted on a clinical trial that opened in 2015 and aimed to maximally reduce the toxicities of transplant for primary immunodeficiency patients. The platform featured reduced intensity conditioning with pentostatin, low-dose cyclophosphamide, and 2 days of busulfan, a T-cell replete bone marrow graft, and GVHD prophylaxis with post-transplantation cyclophosphamide, MMF, and sirolimus. Early results were promising, with low transplant-related mortality and a graft failure rate of 10%, as expected for a reduced intensity conditioning regimen. The patient's history has been described already by Dr. Uriarte, his referring physician. Ultimately, his indication for allogeneic transplant was his immune neutropenia. He received a 10 out of 10 matched unrelated donor bone marrow transplant, which was complicated by sinusoidal obstructive syndrome of the liver, despite the use of reduced intensity conditioning. Remarkably, despite engraftment with donor cells, the patient experienced sudden decline in his neutrophil count concurrently with a rapid loss of his graft and an increase in host lymphocytes early after transplant, as depicted in this graph. He received a salvage non-myeloablative transplant using the same donor but with a peripheral blood stem cell graft. Again, declines in neutrophil count were noted, which were only transiently responsive to various immunosuppressive strategies, along with declines in the donor T-cell chimerism, which prompted donor lymphocyte infusion. Ultimately, the patient attained full donor chimerism and remission of his neutropenia only after developing acute graft versus host disease following the last donor lymphocyte infusion. Our patient is currently 3 years out from transplant without any complications apart from chronic oral graft versus host disease. He remains clinically well with no recurrence of neutropenia off of any immunomodulatory therapy. We learned several lessons from this patient's challenging case. 1, we need more targeted T-cell depletion to eliminate dysregulated host T-cells. 2, increasing myeloablation is not the answer, given the risk of liver toxicity. 3, maybe some graft versus host disease is of benefit to help target residual host hematopoiesis and host lymphocytes as well. And 4, sirolimus may be too good at promoting mixed chimerism. Thus, drawing directly from this experience, we designed a spin-off platform featuring the addition of equine ATG to optimize host lymphodepletion, use of a PBSC graft, use of tacrolimus in lieu of sirolimus, and a shorter duration of immunosuppression. Our next two DADA2 patients were transplanted using this platform. Patient 2 was a 6-year-old boy with pure red cell aplasia since 2 months of age who was transfusion dependent with resultant iron overload. He developed autoimmune neutropenia at 5 years old, which was refractory to filgrastim and etanercept. Upon diagnosis with DADA2, he was referred for allogeneic transplant. A liver biopsy pre-transplant showed severe portal hypertension, hepatoportal sclerosis, perisinusoidal fibrosis, and iron overload. He received a matched unrelated donor PBSC graft, but unfortunately, after initial engraftment with donor cells, rejected the graft and developed severe immune neutropenia again. His second transplant utilized the same donor and the same T-cell replete peripheral blood stem cell graft with non-myeloablative conditioning and again a post-transplantation cyclophosphamide-based graft versus host disease prophylaxis regimen. Unfortunately, donor chimerism declined again and severe neutropenia returned. For his third transplant, the same donor was used again, along with a CD34 selected peripheral blood stem cell graft followed by donor lymphocyte infusion. Conditioning was non-myeloablative with rabbit BTG and fludarabine, and no additional graft versus host disease prophylaxis was used. This graphic depicts the patient's course following his first, second, and third transplant. You can see the rapid drops in neutrophil count, which could not be salvaged with various immunomodulatory therapies and donor lymphocyte infusions. Ultimately, after 5 donor lymphocyte infusions, he developed graft versus host disease and only then attained full donor chimerism and remission from his immune neutropenia. Patient 3 had a much less eventful course. He was a 17-year-old male with a history of polyarteritis nodosa maintained on adalimumab. He developed autoimmune neutropenia refractory to various therapies and was referred for transplant. He had uneventful engraftment of donor cells after a matched unrelated donor transplant, complicated by mild acute graft versus host disease of the skin, but no chronic graft versus host disease and no other major transplant-related complications. Now, 2 years after transplant, he maintains normal blood counts and full donor chimerism and remains off of immunosuppression and TNF blockers. In conclusion, DADA2 patients with immune cytopenia phenotypes are at high risk of graft rejection. Approaches to transplanting these patients must take into consideration the need for significant host lymphodepletion, the risk of organ toxicity and particularly sinusoidal obstructive syndrome in these patients who already have underlying endothelial damage, and the need to closely monitor donor chimerism and aim for full donor chimerism to avoid graft instability or rejection. Thank you for your attention.
Bueno, muy bien. Espectacular el aporte de todos los que han participado. Muchas gracias, Dimana, Dimitrova. Ha sido de excelente aporte y muy buena introducción, el resumen que hemos tenido. Ahora lo que les voy a invitar es, si pueden, vamos a generar un breve para ver en qué anda y distender un poquitito. Acá les voy a compartir en la pantalla. Ustedes van a tener que entrar. Ya les muestro. Van a tener que entrar aquí, en este lugar. En este lugar van a poner un pin. El pin ahora se los voy a dar. El pin que vamos a usar va a ser el siguiente. Y vamos a hacer un juego. Tienen que poner ese número en la plataforma de Kahoot, que es 767533, donde dice ingresar PIN. Y ahí van a empezar, vamos a ver los jugadores que van a empezar a entrar. Son preguntas sencillas, breves, muy chiquititas, para tratar de ver qué opciones tenemos respecto a estos pacientes y si habíamos visto alguno. Hola Jennifer. Bueno, vamos a darle un minutito para que se vaya cargando, para tener algunos jugadores, además de los muchachos que conozco que han trabajado con... Les repito entonces, tienen que poner en esta plataforma, en esta dirección que es kahoot.it, en su celular, en el móvil o en la computadora, ponen el PIN del juego. Una vez que ponen el PIN del juego, que es este, que está aquí, ahora se los comparto, es 767533. Una vez que se pone el PIN de juego, en ese momento esperamos ahí un minutito más y comenzamos a jugar. Bueno, dentro de, como resumen hasta acá y tratando de ver en qué situaciones tenemos en Latinoamérica respecto a esta situación, respecto a la epidemiología y a la frecuencia en DADA2, nosotros esperaríamos que es la primera vez que nos enteramos que existe esta enfermedad. Creemos que es una enfermedad muy frecuente, creemos que es una enfermedad muy poco frecuente, o su frecuencia va a depender del tipo de mutación en la población. Bueno, muy bien. Es una enfermedad poco frecuente, como bien dijo Chip, es una enfermedad poco frecuente a nivel global, pero hay poblaciones que tienen frecuencias más altas, siendo unas frecuencias tan comunes para la mutación en Georgia, que son con una incidencia de 1 en 40 a 1 en 2000 en general, con una prevalencia global de 1 en 400.000. Muy bien, Lore, muchas gracias. Por ahora, Lore, Alfonso y Bárbara. Vamos con la siguiente, que es sobre la forma de presentación clínica esperada. Totalmente, en este caso, todas estas formas son esperadas, incluso otras, como vimos con Leo, como ALPS-like y trastornos autoinmunes, sospecha de linfoma, linfoma Hodgkin, inclusive ha sido relacionado con la enfermedad. O sea, la forma de presentación es muy variable. Vamos con la tercera. Si recuerdan haber visto pacientes similares, ¿alguna vez han visto un paciente como esto? Si les es común o les recuerda alguno que hayan visto que podría haber llegado a tener este tipo de enfermedad. Muy bien, todos contestaron que sí, que alguna vez vieron uno. Bárbara. ¿Alguna vez han pensado en un diagnóstico diferencial dentro de lo que es DADA2? Muy bien. Y la siguiente, y la última, nos faltan, si se han estudiado pacientes y donde ustedes están, en el lugar que ustedes están, han podido hacer diagnóstico o realizarlo en su país o región por estudios funcionales o por estudios moleculares, si han tenido que derivar el estudio fuera de su centro o no han podido, lo han pensado pero no lo han podido resolver. Interesante. Sí, en nuestra región hacer estudios funcionales y enzimáticos es difícil. En general tenemos que derivar muestras, pero es un poco más cómodo hacer los estudios moleculares. Interesante es saber y tratar de generar para el final qué opciones de diagnóstico podemos tener a raíz de lo que nos digan los colegas. Bueno, Bárbara viene tomando la delantera. Y en el caso de que necesitaran estudiar un paciente en el futuro, ¿qué opciones podríamos tener respecto a esto? Muy bien. Bueno, muchísimas gracias por haber... al final, creo que Bárbara se llevó todos los puntos y Leo, felicitaciones. Y en el caso de diagnosticar a un paciente, ¿cómo los tratarían? ¿Cuál sería la estrategia de tratamiento que podrían usar? Muy bien. Bueno, estamos bien y vamos a ver quién fue el ganador del juego de hoy. En el podio, Marta, Leo, y Bárbara. Felicitaciones. Bueno, nos tomamos 5 minutos. Tomamos 5 minutos de tiempo para hacer lo que necesiten, servirse un vaso de agua o lo que sea, ir al baño, lo que ustedes puedan y necesiten en este momento. Y volvemos de aquí a 5 minutos y con la presentación de la doctora Mates sobre genotipo, fenotipo y patogénesis de la enfermedad. Bueno, muy bien. Aquí estamos. Gracias, Alfonso. En la siguiente charla, que ya estamos por comenzar, agradecemos, mira, tenemos auditorios desde diferentes lugares del mundo, qué alegría. La próxima charla va a ser, tenemos el honor de presentar a quien haya sido el presidente de la Sociedad Europea de Inmunología, Isabel Mietz. Ella es doctorada en estudios de células T helper, en modelos de ratón y en asma alérgico. Es profesor muy conocido y respetado en la Universidad de Leuven, en el Departamento de Microbiología, Inmunología y Trasplante. Ha sido también investigador principal en el Laboratorio de Estudios de Inmunodeficiencias Primarias con foco en adenosín deaminasa 2 y ha ganado el grant en este año en ERC y francamente tuvo la loca idea de ser presidente de ESID. Como conté, tiene 4 chicos. Con todo esto ha tenido 4 hijos, increíble, y tiene hobbies como tocar el piano y leer y salir a caminar por las montañas. Le damos la bienvenida y muchas gracias por la presentación a Isabel, que nos va a hablar sobre patogénesis de la enfermedad.
Good afternoon. It's really a pleasure to be here with you and to be able to talk to you about the novel insights that we have gained into the pathophysiology and the phenotype-genotype correlation in ADA2 deficiency. I really want to thank wholeheartedly the organizers for giving me the opportunity to address this very interesting topic with you. So how did I get interested in ADA2 deficiency? Well, actually by the presentation of 2 patients that I was following and the unraveling of their molecular diagnosis. The patient that we first saw here was presenting at age 6 months with severe RSV infection and then with a soft aureus lymphadenitis. And then we found that he had refractory pancytopenia, and we ended up treating the patient with stem cell transplantation. And during the course of the stem cell transplantation, he had a pineal gland hemorrhage and veno-occlusive disease, but he's now more than 10 years out of transplant and doing absolutely well. Then his younger sibling came to our attention at the age of 5 months. We had screened him at birth for underlying immunodeficiency because we were afraid he would have the same condition as his brother. But at birth, everything was fine. And then he came to us at the age of 5 months with HHV6-induced transient erythroblastopenia. He then had extensive HSV, started having lymphoproliferation. We also ended up transplanting this patient. At that time, prior to transplant, we performed whole exome sequencing in this family, and we found that the patients were mutated in the gene that was at that time still called CECR1. And both patients had a homozygous mutation R169Q, which we know now is one of the frequent mutations in ADA2 deficiency. At that time, the disease hadn't been described yet, but Mike Hirschfield performed the ADA2 enzyme activity in the plasma for us, and we found that the patient we had transplanted had normal plasma ADA2 activity, whereas the diseased patients had absent ADA2 activity. The healthy sibling, which was a transplant donor for the first patient, had normal ADA2 deficiency, and the father and the mother, the carriers, actually had intermediate levels. So that was where my interest in ADA2 deficiency was born. So the initial description of this condition in 2014 by the group at NIH and then by the group in Israel already give a very, very good overview as expected of this condition. So the initial condition was described as recurrent fevers with lacunar ischemic strokes, hemorrhagic strokes, ophthalmologic involvement, livedo, hepatosplenomegaly, vasculitis, and also some immunodeficiency features. The second paper in the same journal by the Israeli group was more prominently focused on the vasculitis phenotype with polyarthritis nodosa as a phenotype, and most of these patients share the mutation G47R. Now, with time, we learned that ADA2 actually can, the deficiency in ADA2 can actually cause a very variable phenotype and actually can do it all, and at any age. And here I gathered the most prominent phenotypes that were derived from the literature. And I think beside the recurrent fevers and the stroke and the chilblains and the arthritis nodosa, I think it's really important to realize that these patients can present with hypogammaglobulinemia and even without B cells, as I discovered in one of my patients, with viral infections that can be very prominent, with cytopenia, pure cell aplasia, or bone marrow failure, and also with lymphoproliferation that can be either benign or that can have malignant transformation. So it's really a chameleon disease. And I think one of the features that is at this point still very much unraveled or very much ill-explained is the immunodeficiency phenotype, because as I said, this can be really a common variable immunodeficiency phenotype with hypogamma and absent B cells almost, or it can also be an ALPS-like picture with lymphoproliferation and some autoimmunity. And I'm sure Dr. Gatorno will go and discuss this in depth with you. But at least at this time, it's not been unraveled why this happens. And the same is true for the cytopenia phenotype. So it's at present really unsure why patients develop this severe bone marrow failure and why, for instance, the treatment that are now commonly used, as the Dr. Umbrello will address, are not really very successful in resolving the phenotype that, well, the bone marrow phenotype of these patients. But my topic for you today is actually about the genotype-phenotype correlation. And the ADA2 gene is located at 22q11 locus. It has 11 exons and spans 28 kilobytes. It's a highly polymorphic gene. There's many missense variants described. It's very rich in line and allele repeats, which makes up for the reason why there are so many structural variants also detected in this gene, and why it's also difficult to reach a genetic diagnosis or to exclude ADA2 deficiency by only sequencing the gene with Sanger sequencing. And there's over 200 mutations described that are associated with ADA2 deficiency. The question is, of course, how to defer pathogenicity. And also, can we learn something about a specific mutation that tells us what will be the phenotype in the patient, and maybe how we would anticipate a treatment that goes beyond the typical treatment with anti-TNF inhibitors. So we can have some information at a variant level, for instance, the conservation of the nucleotides, and we can have some in silico tools to help us predicting the pathogenicity. But what is most important is actually to measure the plasma ADA2 enzymatic activity that is that you can measure in the patient. And this is really the key to diagnosis. And you need actually both. You need the genetic diagnosis and you need also the enzymatic function. So ADA2 is in fact like ADA1 and adenosine deaminase. So it differs quite substantially from ADA1 in that it's expressed most prominently in myeloid cells, lymphocytes, also in the endothelium. We know now. We also know that the protein structure differs somewhat. It's a dimer, it's glycosylated, there's a disulfide bridge that connects the monomers. It's also different in its cellular localization. It's secreted, it's probably a lysosomal localization that is predominant for this protein. And there were some questions about the real function of ADA2. Especially because of the optimum pH for ADA2 function, which is much lower than the physiological pH of 7.4 where ADA1 operates. It also has several differences in terms of enzyme kinetics, etc. So it made in the beginning of ADA2 literature, it made us believe that it would have actually less ADA function than ADA1 as such. So this is the gene. You can see that mutations are spanning all of the different domains of the gene and of the protein. And so also this will not tell us really if these patients will have a severe phenotype, yes or no. So I list here a few of the most common mutation. And what is important is that the G47R is typically associated with a vasculitis phenotype, whereas for instance, the R169Q is really a phenotype, is really linked to a phenotype that can be bone marrow failure, vasculitis, recurrent fevers, and all of that. It's important to realize that all ethnicities can be affected by this condition. And then there is the problem of incomplete penetrance and expression of the phenotype and the very variable disease severity within one kindred. There's some questions towards a trigger. Is there a trigger that really sets off the inflammation in the patients? And I think it's also important to realize that carriers can be symptomatic. Now, this work is really going into depth on the genotype-phenotype correlation question, and it's beautiful work by Pugh Lee in Harvard. And what he actually did was a literature review of 186 cases of ADA2 deficiency, adding in total 15 new cases, and then dividing them upon the major phenotype of vasculitis, pure cell aplasia, and bone marrow failure, as you can see here. And then what he did next was actually dividing the mutations per phenotype and looking into the major representation of different types of mutations according to the phenotype. And what was striking here is that patients with vasculitis, more than those with pure cell aplasia and more than those with bone marrow failure as a phenotype, had missense mutations in ADA2, whereas in the bone marrow failure group, there was an overrepresentation of indels, nonsense, and splice-site mutations. And the same was actually true for pure cell aplasia. What was also interesting from this overview is that the age of onset was significantly different between the three major phenotype groups, with vasculopathy patients presenting somewhat later than patients with pure cell aplasia and bone marrow failure, which already hints to the fact that maybe the deficiency in ADA2 is more profound in the patients with the bone marrow phenotypes. And so what he set up was an overexpression assay where he overexpressed different alleles or mutants in a hex cell system. And then in the supernatant, the ADA2 enzyme activity is measured. And what was interesting to see is that compared to the wild type activity, it seems that the mutations that are associated with the vasculitis phenotype, and you see them here, they show actually quite a substantial residual ADA2 activity in this overexpression system. So it's difficult to discriminate this at the level of the enzymatic plasma activity of ADA2, but in an overexpression assay, you can actually discriminate those different levels of activity. Whereas the mutations associated with pure cell aplasia and bone marrow failure, they actually have very low residual ADA2 activity. So huge credits for this work by Pugh Lee and his team. It really shows us that the hypothesis that we could bring forward is that depending on the residual ADA2 activity, which is dictated by the genotype of the patient, whether there's a nonsense mutation, of course, an insertion deletion or frameshift mutation versus the missense, and depending on that level, you can have an expression as pure cell aplasia and bone marrow failure with minor vasculitis features compared to the pure missense with high residual ADA2 activity that have a predominant vasculitis phenotype. And together with this goes the presentation of the patient, the age of the presentation, but also how well these patients will respond to anti-TNF therapy, which is the mainstay of treatment, as Dr. Umbrella will undoubtedly tell us eloquently. So this was the current hypothesis on the genotype-phenotype correlation. Of course, many questions are unanswered. For instance, why does in one kindred a patient with the same mutation have no symptoms whatsoever besides the libido, and another patient has bone marrow aplasia? So those questions are really unanswered, and not everything is solved, but I think the framework is there, and I think we only need to dig a little bit deeper to find the answers to these questions. Now, the final part of my talk is the hypothesis and the current statement of the pathophysiology knowledge. I'm sorry for the typo there. So the hypothesis that was first in place was that ADA2 in fact controls the concentration of extracellular adenosine. Indeed, ADA2 protein was initially identified as the residual adenosine deaminase function in ADA1 deficient SCID patients. There's against this pleads really that in ADA2 deficiency, there are no toxic adenosine metabolites found. Also, it's true, as I told you, that the enzymatic properties really, let's say, favor the function of ADA2 in the extracellular environment in conditions of tumor growth, stress, or infection where the pH is lower. There was also the idea that ADA2 could be a growth factor, especially because knockout of ADA2 in frogs causes developmental anomalies, and also because of the cat-eye syndrome itself, where duplication or triplication of ADA2 causes a syndromic condition. Alternatively, there was a hypothesis that ADA2 plays a role in cell signaling and the regulation of cell proliferation, in that it stimulates proliferation of T helper cells and macrophages and induces differentiation of monocytes into macrophages. There was also the interesting idea that ADA2 could play a role in the defense against intracellular pathogens, especially because serum ADA2 activity substantially increases in MTB infection, HIV, HTLV, and ABV infection. And more so, it could actually be used as and it is being used as a marker, for instance, of TB, pleural effusion, and it can also be used as a marker of several other conditions of monocyte activation. Interestingly, for instance, a group of Bodo Grimbacher proposed that ADA2 could be a DNA sensor. And in fact, if you look into the modeling of ADA2, there is a potential site where DNA could bind. So it's not completely, let's say it's not excluded, but it needs to be confirmed that this could be the case. And it would also be a really interesting, let's say an interesting hypothesis on why these patients develop severe viral infections in the course of their disease. So, but the central hypothesis that was first in place is that after the, let's say, after the first big papers in the New England was that the endothelial integrity is disturbed in the absence of ADA2. And this mainly due to the role of the pro-inflammatory M1 macrophages. So in the absence of ADA2, monocytes are more likely to develop into an M1 macrophage that are the pro-inflammatory macrophages with a lot of TNF-alpha production. That is then actually let's say, disturbing the endothelial homeostasis and endothelial integrity, and really activates the endothelium. And this, of course, is a very plausible hypothesis, right? What is also interesting, because we know that the myeloid line, doesn't only contain the monocytes, of course, there's also the neutrophils. And this is also a beautiful paper from the NIH where they show that neutrophils at sites of inflammation in ADA2 deficiency are very abundantly present. And not only that, there's increased netosis in the tissues in patients with ADA2 deficiency. So here you can see several patients with ADA2 deficiency, and you can see that there is really intensive netosis formation in these tissues. And what is also found is that there is increased low-density granules present in ADA2 deficiency. and that exactly these LDGs are actually more prone to netosis and TNF-alpha secretion. What is also interesting is that adenosine triggers netosis in neutrophils via the adenosine receptor 1A. And then intriguingly, these nets can also stimulate macrophages to release TNF-alpha in vivo. So this really puts TNF-alpha as a central mediator in the disease together with neutrophils and macrophages. So very convincingly. So one of the things I was interested in, and unfortunately was not able until now to really look further into, is the role of endothelial cells, because there's databases that show that ADA2 mRNA is really expressed also in endothelial cells. And what we did, we looked into HUVEC cell lines, and we also looked, in fact, into primary endothelial cells of a patient, not a patient with ADA2 deficiency, but another patient. And we found that there is actually expression of ADA2, not only in HUVECs, but also in the endothelial cells. So we were interested in that, and doesn't make a lot of sense, because if you think about the role of endothelium in the macrophage and monocyte interaction and what this could bring about in terms of vasculitis, it could be a plausible way of thinking about this. So we had TNF-alpha, neutrophils, monocytes, macrophages, and the role of the endothelium. But what came also across is that there seems to be a type 1 interferon signature in these patients. And in fact, here are a couple of patients that we measured interferon score with Yannick Rowe's method. And we actually confirmed that most of the patients had an increased type 1 interferon score. And more interestingly, so patient 5 and 6 are siblings, 8 and 7 are siblings. It seems that the patients that are more severely affected in terms of their phenotype also have increased type 1 interferon signature. So of course, this is speculative with a few follow-up data, but at least that is the picture that seems to be emerging. This patient was also an ADA2 deficient patient, but it was in the course of conditioning for ADA2 deficiency transplant. And it seemed that this conditioning itself actually dampened inflammation in the patient. And so we have found very high type 1 interferon signatures, especially in patients that had not been under any treatment at the time that we were measuring them. Of course, you could ask yourself, is this type 1 interferon signature then really relevant to the presentation, or is it just an epiphenomenon? We did also some bone marrow staining, bone marrow biopsy stainings with Siglec-1 as a central marker of type 1 interferon signature, and we could actually see in the bone marrow of a patient with neutropenia and ADA2 deficiency that there was very strongly increased Siglec-1 expression, whereas in another patient with neutropenia, this Siglec-1 was actually much lower in terms of expression. And when we looked in bulk RNA-seq data of 7 patients versus 7 controls, we could also see that the pathway, the type 1 interferon, and actually also the type 2 interferon pathway, that the genes of this pathway were highly differentially expressed and were more expressed than in the controls. So there seems to be also a role for type 1 interferon in these patients. Now, the fundamental question now for pathophysiology is how can a deficient ADA2 function lead to increased type 1 interferon, type 2 interferon signaling? And especially, what is then the role of the endothelium in all of this? And I think the part of the code was cracked by this beautiful paper in a group from California. And it shows that in the absence of ADA2, that HUVECs, they are actually here treated with silencing mRNA, is that HUVECs have a spontaneous increased phosphorylation of IRF3 and TBEC1 as central mediators of type 1 interferon signature. And also, if you look into the interferon beta mRNA production of these endothelial cell lines, you could actually see that it was increased, much like when you stimulate them with CMV as, of course, a trigger of type 1 interferon signature. And not only that, what they also showed us is what was already expected, namely that in HUVECs, and then probably also in other cells, the most predominant intracellular ADA function is actually made up by ADA1, whereas the most abundant ADA function extracellularly is made up by ADA2. So this is really very nice data to show that much of the endothelial ADA2 is actually secreted. And in this co-culture experiment, they used HUVECs either silenced for ADA2 or not in co-culture with the monocytes cell line. And after 48 hours of co-culture, what they could find is that the cells that had been co-cultured with ADA2 deficient HUVECs had very much increased interferon beta mRNA expression. So this suggests that the mediator produced by ADA2 silenced HUVECs stimulates interferon beta mRNA expression in the monocytes. Now, looking into what mediator this could be and thinking about the central role of ADA2 as an adenosine deaminase, it was thought that this could be deoxyadenosine, which is of course the degradation product, and which would accumulate if there is no ADA2 function. And in fact, this is in fact true that deoxyadenosine can stimulate the monocytes to produce more interferon beta mRNA. So how does this work? Well, the fact is that HUVECs and endothelial cells in general have an equilibrative nucleoside transporter, which takes up the deoxyadenosine from the extracellular environment very rapidly. And then the intracellular deoxyadenosine will be further metabolized in a degradation pathway, with the first metabolite that is formed is deoxyinosine or inosine. And actually this metabolite itself, it's really enough to stimulate interferon beta mRNA expression in these cells. So this is actually how it works. Now you can wonder then, why is there interferon beta mRNA transcription? And this is a beautiful, beautiful work in my opinion. So what they then showed is that in fact this metabolite deoxyinosine inhibits methylation, and the hypomethylation that is then the general problem in the cell leads to an overexpression of endogenous retroviral elements, and specific transcripts that are more hypomethylated actually lead to interferon beta production. So as you all know, we all carry, well, you know, most of our genome is made up of these retroviral elements. And this is really the key to why this deoxyinosine stimulates interferon beta mRNA. Of course, there's many open questions. For instance, is this really also the same for primary patient cells versus the single, the silencing RNA treated cell lines? Does this explain the incomplete penetrance? Is it maybe a trigger that that really kindles this entire system? What is the role of viral infections in this entire picture? And also, it would be really nice to be able to confirm these metabolite levels in patients. So I think really this is the way to work further for the patients and to try and understand the pathophysiology. But until then, I think this really is a beautiful framework to think in. So centrally, there is the deficient ADA2 activity, which then actually leads to an accumulation of deoxyadenosine, which in the endothelial cells is metabolized into deoxyinosine or inosine, then leads actually to a disturbance of the methylation status of the endogenous retroviral elements. And this hypomethylation of several of these elements then leads to type 1 interferon response. And the type 1 interferon in itself can then stimulate actually the release of TNF-alpha by the macrophages. And at the neutrophil level, the accumulation of deoxyadenosine can then lead to increased netosis, which then in turn can again stimulate the macrophages for production of TNF-alpha. So I hope to have convinced you that ADA2 deficiency is a very complex inborn error of metabolism, immunity, whatever. Definitely there's a central role of monocytes, neutrophils, and the endothelium. And the ADA activity is central to the pathogenesis, it seems. There's many unanswered questions. Despite the beautiful work on the genotype-phenotype correlation, we are still stuck with incomplete penetrance, the question of triggers, the bone marrow failure that is ill-explained, and the immune deficiency that needs more explanation. There's type 1 and type 2 interference signature and TNF-alpha that definitely play a role in the pathophysiology, but how exactly it leads to all of the manifestations is still to unravel. And I think also that the stem cell transplantation success that has been published really suggests that hematopoietic cells may be the central drivers, after all, of the disease, as in a cohort of 30 patients. These patients were all cured of the vasculitis, the bone marrow failure, and of the immunodeficiency. So despite the fact, of course, that the endothelium was not replaced. So there's still many open questions, and there's still a lot of work to do. But I want to thank you for now, and I want to really thank all of the, let's say, collaborators, all of my inspiring colleagues abroad, and the patients and their families who really, trigger me to look at this further and to really study this disease further. I want to thank also the funding organizations for this. Thank you very much. And by the way, I'm also always ready to help you with diagnosis or whatever tests you want to run. Thank you.
Muchísimas gracias, Isabel. Espectacular charla, muy completa. Vamos rápidamente a presentar al doctor Gatorno, a quien no hace falta mucha introducción. Es el presidente de la Sociedad Internacional de Enfermedades Autoinflamatorias Sistémicas, es el jefe de la unidad de enfermedades autoinflamatorias e inmunodeficiencias en el Hospital Gaslini en Génova, al cual tenemos muchas ganas de visitar y conversar con él ahí mismo en Italia. Gracias, Marco, por tu presentación y por la charla y por participar. Buenas tardes aquí y buenas noches allí. Marco, vas a necesitar compartir pantalla, ¿verdad, Alfonso? Lo vamos a tener que dejar compartir. Ahí estamos.
Thank you very much for inviting me. This is Marco Gatorno. I'm from Gaslini Institute in Genoa, and it's a great pleasure to not to see you, but at least to participate to this webinar. My intention is now to talk about the clinical presentation and some consideration about the diagnosis of DADA2. I start with these two guys that we see some years ago. Luca and Simone, you can see here. Luca at the age of 2 had livedo reticularis, fever and inflammation. After a few weeks, he has a paralysis of third cranial nerve with a huge hemorrhagic stroke that you can see here. The skin biopsy was positive for polyarteritis, classical signs. He had a good response to thalidomide. At that time, he used thalidomide and steroids. But as soon as we have to withdraw thalidomide because of peripheral nerve modification, he had second episode of strokes. You can see here. And also Luca has hypogammaglobulinemia. Some years later, we have another boy, Simone, that at the age of 6 months, he had fever and livedo reticularis with elevation acute phase reactants. Fever, abdominal pain at certain points with an evacuation, and there was an intestinal resection that had an histological evidence of polyarteritis. after 1 year, he has hemiplegia for an ischemic stroke again. So two very similar cases, and it was what was quite important that Luca and Simone were brothers. So it was clear that at that time, 2007, there was a genetic disease. We looked a lot for finding the cause, thinking that they were homozygous for a possible consanguinity, but that was not the case. We have the chance, of course, to get through these two very important papers, one from the group of Ivona Xantievich and the other from Israel, that indeed, at the end of the day, give us the answer of what our Luca and Simone had. Indeed, the DADA2 that was discovered, as you see here, 14, with the classical vascular involvement, the skin manifestation of polyarteritis nodosa, with the skin manifestation, livedo racemosa or reticularis, the histological features, and different skin manifestation that you can see here. Together with this typical skin manifestation and inflammation, also it was clear from the paper from New England Journal of Medicine and absolute experience of Luca and Simone also that the neurological manifestation, strokes, seizure, and different kind of central nervous and also peripheral nervous system were important in this disease. This lead to us the first cases, of course, were let's say screened by Ivona Xantievich and NIH. Then we try to identify together with our geneticists in general the possible presence of similar cases in Italy. So we asked in all pediatric rheumatology groups if they have similar patient with early onset panarteritis and or neurological manifestation, very early onset neurological strokes and so on in the context of systemic. So we were looking essentially to the inflammatory part, to the rheumatological part of the disease, because that was at the beginning the main clinical features. And what was quite interesting, of course, was to have at home, in-house, in our lab, enzymatic activity that was done on monocytes of circulating monocytes of this patient, and was able to analyze the supernatants with HLA-C after stimulation with adenosine in the presence, of course, of a DADA1 inhibitor. This was really important to have in-house this test that is not that, let's say, easy, because it's done on freshly isolated cells. It's not on plasma or dry spot, but it's really important, was really important to have it in our lab. We were able to find out a number of different variants and a number of cases, and also with this rather typical Italian, we say, mutation that was present in almost 50% of our alleles. The clinical presentation in our cohort that I remember to you that was related to essentially pediatric rheumatology patient was livedo reticularis or racemosa, then nodules, you can see here, ulcers, and a relevant number of different neurological manifestations. I will come back on this later on. What was, you can see here, this Luca that have this paresis is still unfortunately ongoing, was persistent, and you can see here another important clinical features, that is sudden hearing loss. This is something that occurred in 3 out of 17 patients that we were able to screen in the first Italian paper. How can we distinguish DADA2 from the typical multifactorial pattern? Because at the beginning of the story, we asked to screen for all the patients with panarteritis that has been followed in our centers in Italy, and it was quite quite interesting it was to see that indeed there was some differences between the patient that have a genetic confirmation of DADA2 in respect to the patient with a negative genetic test, but with panarteritis. You can see here some hints, for example, the disease onset. You can see here much lower in DADA2 patient. And other important things is the higher relevance of livedo reticularis, presence of Racemosa in DADA2, and vice versa, much higher presence of nodules, subcutaneous nodules in polyarteritis nodosus. And again, a rather important difference, as you can see here, is the CNS involvement that was much more present in patients with DADA2. Is genetic always reliable? This is
Ahí se dejó de escuchar un poquitito. Le vamos a pedir a Marco si puede volver a conectar. Cosas de la virtualidad que nos suceden. Please, Marco, if you can connect again.
Okay.
We lost connection.
Can you write Marcos, Ignacio?
Yes, we already did it.
My attention is now to talk about the clinical presentation and some consideration about the diagnosis of DADA2.
Listen.
With these two guys that we see some years ago.
Marco?
Yes.
Marco, are you there? Marco?
Yes,
we lost connection of your presentation, Marco. Can you please? Yeah, we don't know what happened, but we lost connection on your presentation. If you can, it's in about after the.
Yeah, I've seen that, but I'm not sure that I'm able to restart from here. However, I try to do that.
Okay, let me see.
I'm sorry, but I try to restart from here. Maybe I have
Alfonso, can you restart from when Marco leave it? Le pedimos paciencia, por favor, al auditorio. Estamos tratando de reconectar.
Hello, thank you very much.
Can you see my presentation or no?
No, Marco, you have to share your screen. You have to share your screen.
Just a moment.
And it's a great pleasure not to see you, but at least.
You have to move forward.
Yeah. Can you see now?
Yes, now yes. And is in yes, here.
Okay,
excellent.
So
excellent, Mark.
I can start from here.
Yes, please, Mark.
Okay, just a moment. Okay.
In DADA2, and vice versa, much higher presence of nodules, subcutaneous nodules in polyarteritis nodosus. And again, a rather important difference, as you can see here, is the CNS involvement that was much more present in patients with DADA2. Is genetic always reliable? This is a very important point that I would like to make with you and discuss with you. Among the genetically negative patients, DADA2, we had this patient from Sardinia that was really, really strange because she had a disease onset at 15 months with fever, elevated reticularis, and myocarditis. That is rather important. She had hypogammaglobulinemia, and what is much more important, that she had 3 different stroke events. So she had a clear-cut DADA2 for many conditions with persistent inflammation, but the Sanger sequencing was completely negative. And here was really important to have not only the clinical but also in-house the enzymatic activity that showed that as for the patient with DADA2 in comparison to control, there is a complete inability to secrete immunosin in this patient, like the patient with DADA2. That was in this patient that had a complete loss of enzymatic activity. That later on was also confirmed by Mark Hershfield at Duke University on patient plasma some years ago, later. So that is quite an important topic and important issue because the gene where DADA2 is on the chromosome in which DADA2 is on is chromosome 22q11. And you know that this is a really unstable region, subject to copy numbers variation and low copy repeat sequences or segmental duplication. Using whole genome sequencing, we were able to identify in patients a huge homozygous tandem duplication that was received by both parents, encompassing a large part of the exon 3 and exon 4 of the DADA2 genes. And of course, was related to a completely loss of function of the protein. This is quite interesting because you have to look very carefully. And this is also the possibility for other patients. There are plenty of patients that at the first screen can result to be heterozygous. You have to be very careful. This is, for example, is a story of 2 twins that we collaborate in the genetic analysis, in the screening phase, in the diagnosis. They are followed now by our friends and colleagues from San Raffaele Hospital in Milan. They have a clear-cut clinical features of DADA2, one of them also with a severe neutropenia. We will talk about that. But at the beginning, they were heterozygous. It was very important to have, again, an enzymatic activity that was absolutely positive. Patients were severely affected in terms of enzymatic activity. And the only way to find out the second variant was the multiplex ligation dependent proamplification, MPLA. We were able to identify a deletion in the other allele that was, let's say, inherited by the so what about the neurological imaging, neuroimaging findings? And very recently, we published the experience of a number of these patients following in Italy, and that were evaluated by very expert pediatric neuroradiologists in a consensus. More than 60 exams in the baseline and the follow-up is a very interesting, the variety of neurological features that we can observe. You can see some intracranial hemorrhagic manifestation here, acute brain ischemic infarct. Here you can see a chronic brain ischemic lesion that you can see in several, but sometimes they can also be asymptomatic. What was quite interesting and very peculiar in some patients is the presence of this perivascular enhanced tissue. This is rather typical, rather unique. This is something that was related at the beginning of the disease, and what was quite striking that this tissue was completely removed and resolved after anti-TNF treatment. Other condition, some patients can have a posterior encephalopathy that was reversible, and then some other can have intracranial aneurysm, and others a chronic brain and medullary ischemic infarcts. So a number of different conditions in this disease that of course is rather scary for the possible neurosis. But now we know that there is much more than vasculitis and stroke condition, thanks to the work of our friends in Germany, the group of Bollock and Bacher. It was clear that if we look to the patient in the basket of patients that are followed for antibody deficiency, a relevant number of these patients, 11 out of 181, are indeed carrier of DADA2 mutation. This is quite important. So now it's clear that beside the vasculopathy and inflammation, and beside immunodeficiency, there is a relevant number of patients that have a very important hematological manifestation with poor red cell aplasia, thrombocytopenia, pancytopenia, and they can of course have also rather important viral bacterial infection. It was the work, I think, from Pouilly in Jachi last year. He was able to go back to the literature and to see the clinical picture of the different cases so far reported in the literature. It's very important to see that indeed the patient with vasculitis have a higher chance to have a missense mutation, while patients with a more severe hematological manifestation have a higher prevalence of deletion or nonsense mutation. This is rather important. It's also related, and he did a fantastic job in identifying the functional test of DADA2 activity in this different type of mutation, missense, deletion of nonsense. And it was clear that there was still some enzymatic activity in some patients with missense mutation. And so it is clear that the patient with a more vasculitis and inflammatory phenotype have higher chances to have some more residual adenosine 2 activity, and whilst those patients that have more severe variant and mutation have less DADA2 activity and more possibility to have severe hematological manifestation. This is rather important. New diagnosis and new phenotype. After the first experience in 2017, of course, in the last 2-3 years, we were able to identify or to, let's say, help for the identification of many other patients in Italy, at least 10, with a variety of different clinical picture. We have the example of Fabio that started when he was 8 years old with a myositis, and then he started to have low-grade fever, splenomegaly, and very diffuse lymphadenopathy. He was absolutely normal before. The workup was absolutely not really informative. He had an inflammatory infiltrate in the biopsy. The lymph node was absolutely normal, just a reactive lymph node, and he had to have a lot of lymphoproliferation and acute phase reactions. Through a panel, there was a surprise to have two homozygous, one homozygous DADA2 mutation with a pathological enzymatic activity. So a lymphoproliferation, sometimes in some patients with certain ARPS-like phenotypes, could be one of the possible manifestations of DADA2. Another example of another important issue came from these two patients, two brothers, that we studied with the colleague from Monza near Milan, and they find out these patients with these two compound heterozygote mutations. What was quite interesting that the phenotype was absolutely mild, with mild leukopenia, hypogammaglobulinemia, splenomegaly in this patient, and the second patient was rather completely asymptomatic. They have, again, here in our hand, a complete enzymatic defect. What was quite important is the fact that they were completely asymptomatic, but one patient displayed in the blood smear large granular lymphocytes with high percentage of T cell perturbation. This is rather important because LGL has been described in one adult patient with DADA2, so we have to consider for these cases how to do with a symptomatic patient, when to start the treatment, and in the other hand also the importance of a possible, a careful evaluation and long-term follow-up, also in terms of the possible risk for leukemia or other hematological condition. I will start ahead with Anna Tao, that is 12 years older with a Vietnamese origin, that was adopted at the age of 7 months. She had some recurrent fever episode, and she had a striking susceptibility to viral infection, parvovirus, varicella, and so on. She had also 2 episodes of MAS with a viral trigger associated with a sterile encephalitis in one case. You have a mild hypoglobulinemia at certain points. She do not respond to steroids and or anakinra, but she responds rather well to high doses of immunoglobulin every month. It was really, really strange. We sent to the Botswood Canberra's lab to make the whole exome sequencing just to NGS panel, just to make to look for some immunodeficiency. It was quite interesting that the results that come out was the presence of homozygous missense mutation that was not known. She had in our hand afterwards again a complete enzymatic defect that was also confirmed by Mark Hershfield at Duke University. She went on with just immunoglobulin, but at a certain point she had some ulcers that were rather important at the level of genital ulcers, several genital ulcers that were completely controlled by anti-TNF. Very strange case. And I finish these strange cases with this adult patient that since the age of 8 years, he had a lot of different problems, and he was referred to us after recurrent fever, hypogammaglobulinemia, neurosensorial hearing loss at the age of 9, vasculitis, strokes, bowel ischemia, a lot of trouble, a lot of disease treatment. And just when he was 42, he was referred to us to make the diagnosis with a pathologist. So this is a very important point, the final point, the problem of the diagnosis in adults with a long course, because they can have a very high disease. This is why we are now facing a very important project in Italy to supported by the grant by the Italian Ministry of Health to support the diagnosis in children and adults is very important. So in conclusion, DADA2 is a new clinical entity that is a wide clinical variability. We have to increase the awareness to the hematologists, adult rheumatologists. We have to make a careful evaluation of the genetic results. The importance of a reliable functional test is very important to suspect the diagnosis and to go on with the genetic analysis. There is still a lot of open question how to do with a symptomatic patient. There is a continuous expansion of the phenotype, so that's why we need a national registry. So this is thanks all the people that are working with me in Gaslini Institute in Genoa for this topic, and to invite you to go to the East Side meeting, because tonight and this year there will be a periodic congress from May to December, 2 sessions every month. That would be, I think, very important and very interesting. Thank you very much indeed.
Bueno, muchas gracias Marco, espectacular como siempre la presentación, estamos cortos de tiempo, así que vamos a pasar a presentar a Amanda Ombrello, que es una gran amiga. Amanda tiene muchísima experiencia en enfermedades reumáticas y autoinflamatorias, se ha recibido de médica en la Universidad de San Luis, Missouri, y en el 2010 empezó a trabajar empezó a trabajar en NIH con el Dr. Dan Kastner y ha sido la líder en el equipo de enfermedades autoinflamatorias en el NIH. También ha participado y ha descubierto 6 enfermedades autoinflamatorias nuevas, ha contribuido enormemente al diagnóstico de estas enfermedades y al tratamiento, y es un referente mundial en esta patología también. Una vez finalizada la presentación de Amanda, vamos a dar cierre y algunas preguntas cortas a los presentadores y les agradecemos porque estamos cortos de tiempo. Muchas gracias.
Good afternoon. Thank you so much to the organizers for inviting me to be a part of this with you. I'm here today to talk to you about the treatment of DADA2 in 2021 and where things stand and where we can hope the future may take us. So let's get a little background first as to how the treatment options for DADA2 came about. Well, it all started back in 2002 when the initial patient who has DADA2 was initially seen at the NIH. Of course, it was unknown what she had at that time, but she did have a history of strokes and fevers and rashes. She was followed by the clinic for the next decade until 2011, when another little girl from Texas presented to our clinic, and she too had a history of fevers and rash and strokes. And these were the early days of our whole exome sequencing. And we decided, because strokes were very, very rare in the autoinflammatory clinic, that we would send these 2 girls for sequencing. And we found that they both shared a mutation and then had second mutations in the ADA2 gene, which was formerly known as the CECR1 gene. So when we saw these patients, because quickly thereafter we found some additional who had 2 mutations in the ADA2 gene, we started performing some biopsies on them, some skin biopsies, trying to investigate what was going on, because we saw the large medication list that they had been on, and they had all continued to have strokes while on their medications. So when we did their skin biopsies and we did some immunostaining, you can see that all the red you see in these pictures here are indicative of TNF alpha being around the blood vessels. And then compare this to the 2 controls down here in the bottom panels, and you see that there's absolutely no red at all, which means there's TNF that is surrounding these patient blood vessels. And knowing that, and that we had heard from some colleagues over in Israel who also had some patients with DADA2, that there had been one patient who had been treated for an inflammatory bowel disease picture with an anti-TNF agent, and that patient happened to be doing well. It was then that we started etanercept therapy on our first 3 DADA2 patients. That was back in June 2016. And we soon saw that the patients were feeling better. They weren't having fevers anymore. Their rashes were better. And that as time went by, we observed that they weren't having more strokes. These were children who had had 5, 6, 7 strokes in their first 7 years of life. And carry that forward to February of 2014, and that is when DADA2 was initially published as back-to-back articles in the New England Journal of Medicine. And quickly thereafter, we started seeing an influx of more DADA2 patients. So by September 2014, we had 11 patients on anti-TNF treatment. And fast forward to April 2021, and we now have at the NIH 51 of our 60 patients with DADA2 on anti-TNF agents. So the treatment of DADA2, as I was saying, we observed that they were clinically feeling better, and that as time went by, they weren't having the strokes anymore. So we decided to do an analysis a few years ago of the first 15 patients who had DADA2 in our clinic and history of stroke. And we found that prior to anti-TNF treatment being implemented, they had had 55 collective strokes over the course of 2,077 patient months. And then after anti-TNF initiation, they had had no strokes over the course of 733 patient months. And we did a matched follow-up timeline and found again that there was this very statistically significant decrease in strokes. And this finding was rewarded as a follow-up publication in the New England Journal of Medicine in April of 2019. So like I said, though, we have far more than 15 patients in our cohort now. So again, if we look at them now, we see that in the 58 patient analysis that was done back in November of 2020, there were 24 patients who had had a history of stroke. And on this table here, the red and yellow times indicate the time in a person's life prior to having anti-TNF agents on board. And within those red and yellow bars, you can see these black circles. Each of these black circles represents an ischemic event occurring in these patients. And as you can see, on each person, as you go line by line, they had their strokes in either the red or the yellow portion of the graph, but in the greenish blue, you see absolutely none after anti-TNF therapy was started. And so we still have very strong statistical significance here that now we have 78 total strokes in the pre-treatment period of 3,623 patient months. And then when we have them on treatment for 1,752 patient months, we have seen 0 strokes. So this makes us feel very good that the anti-TNF has proven to be quite effective in one of the most devastating parts of this disease. And one other thing you can see here is that as we've gotten better at diagnosing DADA2, the time in the red and the yellow is not as long. We are identifying these patients sooner and we are starting treatment sooner, therefore allowing them to meet milestones that they might not otherwise have met. So I'm showing you what we've observed clinically, but then remember those skin biopsies that we showed earlier? Well, we brought some of these patients back to do repeat follow-up skin biopsies while they were on anti-TNF. So in the top row here, you see these are the patients prior to going on anti-TNF. And again, the red is indicative of the immunostaining for TNF alpha. We have controls over here on the left, but these all are the patients. And you can see in each biopsy, there is some red perivascularly. And then in their follow-up biopsies, you can see down here in the lower row is that there's absolutely no more red. So the TNF alpha inhibitors are doing exactly what we want them to do in the vasculature. Now, as far as growth and development goes, we also see that there can be marked catch-up growth. Here we have a little girl who in June of 2013 was implemented on etanercept therapy. And as you can see, she was small. She was on a prednisone dose of 0.4 milligrams per kilogram per day. And her height was less than 3rd percentile. After 3.5 years on anti-TNF treatment, you can see that her height has ascended to the 25th to the 50th percentile, and her prednisone dose was now 0. Fast forward again, another 2.5 years, and you see she's continued to have catch-up linear growth with her height being at the 50th percentile. And she was on some steroids though at this time. And this was just a short course of them because she had developed kind of an optic neuritis breakthrough picture, which is going to segue nicely in a couple of slides here to showing that although anti-TNF agents are great for a lot of the manifestations of DADA2, they do not solve all of the problems. We see that there's a lot of hepatic disease in the patients who have DADA2. And when we've biopsied them, we've seen that they all have abnormal liver biopsies. And as you can see again, here in June 2013, we have a little girl who has marked splenomegaly with a spleen size of 16 centimeters. Fast forwarding to 2017, where she's had marked linear growth, and her spleen has actually shrunk in size to 15.1 centimeters. And then fast forwarding again another 2 years, and her spleen has actually gone from being considered splenomegaly to a normal spleen size of 14.2. We also do what's called a fibroscan or transient elastography on our patients to measure the liver stiffness. And normal would be less than 7 kilopascals. As you can see in all of our patients who we did this pre-anti-TNF initiation, we had some patients who fell well beyond that 7 kilopascal cutoff, but that with treatment, almost everyone has come down into the normal range. We do have a couple of patients who have been on the rise, and this is because these are patients who have pure red cell aplasia and have been having some iron overload into their liver, causing them to have stiffer livers. When we look at their blood tests, we see that there is a marked decrease in the inflammatory burden, that SED rate and CRP. If they have an anemia of inflammatory disease, we see that that can normalize into normal indices. We can see that their white blood cell count can come down from an elevated level into a normal level. So many things improve. And then on a more subjective nature, for the livedo racemosa, the families and the patients feel that over time there's less livedo pronouncement. But as you can see, over the course of 6 years in these 5 sets of the same leg, you can always see that there is still some livedo present. So it does not completely resolve, which leads us to say that although we see no more TNF staining around the vessels, there is still some vessel involvement that is not being treated by anti-TNF. And to further this, we have had a patient who had severe peripheral vascular disease prior to going on anti-TNF progress over the course of 5 years to having increasing cyanosis of his digits, necessitating some partial toe amputations. But then there are those patients who do become more and more complex, even on anti-TNF. So how do we go about treating them? Well, you can have patients who have breakthrough inflammatory episodes. So what do we do? Well, we consider, are the patients on anti-TNF? And if so, are they on etanercept, which is the fusion protein, or are they on a true monoclonal antibodies? For the patients who are on the monoclonal antibodies, we find that sometimes they develop neutralizing antibodies to the drug. And for that point, we have initiated therapy with methotrexate for a number of them to try to prevent this. This doesn't happen in the patients who are on etanercept. But if they still have breakthrough inflammation, we might consider changing the anti-TNF agent. And sometimes we find that with a change from etanercept to one of the monoclonal antibodies, such as adalimumab or infliximab, that we have improved control of their disease again. But then there are some that, despite us changing an anti-TNF, will still have breakthrough inflammatory periods with breakthrough rash or breakthrough fever or elevation of their inflammatory markers. And for them, we have found that sometimes using a short course of an anti-IL-1 agent, we can bring their disease back under control, because what they tend to have is just a flare period, and then they settle back down into their baseline. We got the idea to try this based upon Dr. Carmona Rivera's publication in Blood in 2019, which showed that the DADA2 patients had a lot of LDGs, low density granulocytes, that were producing the neutrophilic nets. And when those were produced, it resulted in an inflammatory milieu with a lot of TNF-alpha released. And then when they used the anti-IL-1 agent, the receptor antagonist anakinra, that it would reduce the release of these cytokines and reduce the inflammatory burden. So again, for some of the patients who have inflammatory breakthrough with documentable inflammation, we find that they respond very nicely to a short course of anakinra. But this doesn't help everybody. So for instance, if you're a patient who has neutropenia as part of your disease, or other forms of bone marrow dysfunction, or some of the peripheral vascular disease, we've tried anakinra and not really had much success using it to get their disease back under control. And so we have to consider, what do we think is going on in some of these other manifestations of DADA2? Well, in regards to the neutropenia, when we do bone marrow biopsies on some of these patients who have very, very low ANCs, we find that when we do an MPO stain for myeloid cells, that there is a growth arrest of the myeloid cells very early in maturation. And then adding to this, we find that there is a huge influx of CD3 T cells, or CD3 stained T cells in the marrow, which aren't supposed to be there. So we look at this as being more of an immune mediated neutropenia now, with T cells being the bad guys causing the neutropenia. So we've considered, how can we do a more T-cell directed therapy in these DADA2 patients with neutropenia? Well, we found that we've used some cyclosporin coupled with some low-dose glucocorticoids and an anti-TNF in a few patients, and have found that we've been able to get neutrophil counts to rise again. We've also found in the transplant patients who are headed to transplant that we really have to hit them hard and with the T-cell directed therapy such as ATG or alemtuzumab to really make sure we eradicate the host lymphocytes prior to transplant. But in regards to the cyclosporin, here you can see on this timeline is a boy who presented to the NIH with his DADA2, and he had very low neutrophil counts with an ANC of going to 0 sometimes. And he was going to go for transplant, but we still had a number of months before his transplant was going to arrive. And we couldn't have him with ANCs of 0. So he is the first one we tried with the cyclosporin and the prednisone dose of 10. And he was also on adalimumab. And you can see that when we started these drugs on him, the cyclosporin and the glucocorticoids, his ANC rose, and it rose over the course of time to when he came back to the NIH in January 2019 for his transplant. At that time, he had normal neutrophils, if not high, and they remained in that range until we depleted him in his conditioning regimen for his transplant. And as you can see, he's gone on post-transplant and done very well, and it has maintained his ANC in a normal range now that he's cured from his disease. So speaking of transplant, we have recognized now for a number of years that hematopoietic cell transplant is an option for these patients. It's curative. And with Isabel Metz and on a lot of other transplant doctors from around the world, we have just compiled a report on 30 patients with DADA2 who have undergone 38 transplants. And the great news is that we have a 97% survival rate at 2 years. The transplant indications were overwhelmingly due to various bone marrow dysfunctions like the cytopenias, and then a malignancy or lymphoproliferative disease in a patient. Notably, 14 of these patients had seen anti-TNF agents prior to their transplant, and the anti-TNF agents were not effective enough at improving their marrow dysfunction. The conditioning regimens were varied from myoablative to reduced intensity and a couple with non-myoablative. And notably, 2 patients who were transplanted with a sibling who was actually affected, although that was not recognized at the time, both had graft failure due to the fact they were transplanted with another DADA2 patient's cells. We've also had 2 additional patients where graft failure occurred. And like I was saying in the previous slide, we found that we did not adequately eradicate those host lymphocytes. And so they came back. And when they came back, they again caused the marrow failure by attacking those developing myeloid cells. So these patients required a second and third transplant in one case too. And then again, one more notable thing is that 2 patients were transplanted with an ADA2 heterozygote carrier sibling. And of note, both of those patients right now are doing fine. So what are the considerations you might have if you're having a patient who's going forward with transplant? Well, like I've been saying in the past few slides, very aggressive lymphodepletion seems to be key to a good outcome. Because the DADA2 patients do have the liver dysfunction, we've found that a pre-transplant liver evaluation and biopsy is strongly recommended so that the transplant team goes into the transplant recognizing in what state the DADA2 patient's liver is functioning. And then there is still a great debate as to whether or not the carrier siblings or carrier relatives should be considered as donors, because there can be great variance in the ADA2 enzyme activity between the carriers. And there is concern that there may be some symptoms that can break through if the enzyme activity drops low enough. However, if there are no better options, as you can see based in the 2 who have received their carrier sibling transplants, there are instances where they're doing quite fine. Now on the horizon, but not yet developed, is the gene therapy. And they're working over in the UK and Italy at developing gene therapy programs for these patients. So what to do and what other things could we investigate in these patients? Well, we have seen that they do have a very strong interferon signature, much like those patients who have Aicardi-Gutierrez or other forms of the interferonopathy disease. As you can see here, this nice red is indicative of a DADA2 patient who has marked upregulation of their interferon genes. Now, to date, there really hasn't been trials or patients who have been using the JAK inhibitors because the anti-TNFs have proven so effective with stroke reduction. It's kind of nerve-wracking to consider putting somebody on a different medication. But that is a possibility, a possible avenue to explore in the future. And then a year ago at the NIH, we did a very big, deep immunological study on 17 autoinflammatory and immunodeficiency conditions. And what was very notable in the DADA2 cohort that was screened was that they had elevation in IL-23. And we're not just talking mild elevation. As you can see here, we have a table, our graph is showing some familial cold autoinflammatory syndrome patients, familial Mediterranean fever patients, patients with GATA2, GATA2, and some other disorders. But here we have the DADA2 patients. And as you can see, they have much, much higher IL-23 levels. And DADA2 was the only condition in the study that had that elevation of the serum IL-23 concentration compared to healthy individuals. And then when we looked at the patients who were involved in this study, it was interesting to note that the IL-23 concentration trended higher in those patients with more severe disease. As you can see here, the highest IL-23 was observed in a patient with DADA2 who had trilineage marrow failure. So that, coupled with the fact that it correlated with the serum interferon gamma elevation in these patients, leads us again to consider whether or not a drug like ustekinumab or another anti-IL-23 agent could be used in these patients. So summary of the anti-TNF effects, going back to that, is that we see clear benefits in ischemic stroke risk reduction, inflammatory burden, the inflammatory rashes, the growth and development improves, and then we did see improvement in the transient elastography on the liver evaluation. There was little to no effect on patients who had pure red cell aplasia and peripheral vasculopathy, and sometimes a very modest to somewhat more robust effect of the hepatomegaly, splenomegaly, neutropenia, and immune deficiency. There's still so much we don't know about DADA2 and we have yet to understand, such as, is there a genotype-phenotype correlation? Well, Dr. Pui Lee actually looked at this and published just last year the fact that the patients who have more of the insertions, deletion, and frameshift mutations, that when screened, they're the ones who have virtually undetectable ADA2 enzymatic activities. And contrast that with the more missense, nonsense mutations of patients who have more of an inflammatory features of disease without the marrow dysfunction, you'll find that there is some residual, still very low, but there is residual ADA2 activity going on. And so this leads us to consider, as we still have so much to learn about DADA2, what is driving these enzymatic activity independent functions like the vascular inflammation versus the enzymatic activity dependent functions? And are there ways that we could explore other treatments if we could just start understanding these pathways a little more clearly? Well, that remains to be determined because we just don't understand enough yet. So that is, in conclusion, where things stand right now. If you have it available, anti-TNF agents are great for a lot of the features of DADA2. If you don't have it available in your country, some patients have been treated with thalidomide, as it can also block TNF, and they've had some success. There are biosimilars that have been used in patients with DADA2 with efficacy. Then again, you can consider the transplant route, and then there are those new avenues with the IL-23 and the interferon signatures that have yet to be evaluated. Again, I'd like to thank you for your time. I'm happy to answer any questions. I couldn't do all of this without the help of my wonderful team back at the NIH and all of the consultants who have so graciously given their time to do these 60 patients so that we can all learn how to treat these patients better. Thank you very much and have a wonderful rest of your day.
Excelente, Amanda, muchísimas gracias por la presentación. Ha sido increíble las charlas que se han presentado. I think la tenemos Jennifer Canacry in Dimanas Dimitrova's Zoom. How are you, Jen? I have some for all of you. Thank you for the interpretations. I have some Q and answer fast because of the time, and not to exceed on your help and support. And what about asymptomatic and carriers? I think we run of it. If one of you can just pick the team and answer that.
I'm happy for asymptomatic patients with DADA2. You know, that's a very tough question for which we don't know enough yet to know really, is there ever a time where somebody with DADA2 is not at risk for having a stroke? Like we can't foresee who's going to have strokes. And so if they're truly asymptomatic, some opt out of taking anti-TNF agents, but we had one patient like that at the NIH where he opted against taking it. And then within a year at age 21, he had his first stroke. So from my standpoint, I tend to err on the side of caution. And if it's available to the patients, I strongly encourage them to consider anti-TNF treatment, because there's nothing that can change one's life faster in a moment than a stroke.
Thank you, Amanda. Thank you very much. And what about another options if anti-TNF is not available? What about, say hi to Michael if there is around you. Michael Umbrello, how are you?
They're asking how you're doing, Michael.
I'm doing well. Thank you for asking.
He's doing well.
Thank you, Michael. Now, what about another options in treatment? Because of if here in Latin America or in any part of the world, you can access easily to anti-TNF treatment. What about another options like, I don't know, JAK inhibitors, anti-L1 treatment, maybe thalidomide or steroids?
I just can comment
yes,
on.
Marco.
Oh, thank you. On thalidomide, because we have this strange experience when we collect our Italian series in different centers, and it was very strange that there were, every center had at least one patient that had a good response to thalidomide, and some of the patients still have a complete control after many years of treatment. Some others, I have to say, that have to withdraw the treatment because of the neurological complication. You know, thalidomide has an anti-TNF effect. Of course, if you really have problems and troubles, even if it's not a very easy to handle drug, that could be a good anti-TNF agent if really have trouble in find anti-TNF. For JAK inhibitors, I would like to have an idea from Isabel that I really would like, after her fantastic talk, what does she think about that?
I think it's a very difficult question to answer, because I tried it actually in one patient, and then I stopped it due to side effects. And another hesitation I have is actually that when we are following now prospectively the type 1 interferon signatures during treatment, so I have several patients with neutropenia and that I'm following and trying to decide to transplant yes or no. And so after Amanda's advice to use also cyclosporin, I added a very low dose of cyclosporin. And what actually happened is that the type 1 interferon signature didn't change. I mean, It dropped dramatically after starting TNF inhibition. And then after adding cyclosporine, the neutropenia resolved, but the type 1 interferon didn't change the signature. So I'm less, willing to think or to believe that the type 1 interferon inhibition will help us. So I think, as Amanda said, it seems that sometimes a switch or an addition of one drug to another may help in, I don't know, shifting some inflammation, but I'm not sure it will result in a sustained, for a while, yes, but not for long. And the problem in this patient was that she, on the treatment, also got thrombopenic, had increased creatinine, and then, adding this on top of something else, I didn't feel like doing that.
Excellent, thank you very much. What about treatment failure? You all of three talk about some in a kind of this, and considering treatment failure, the follow-up. How frequent do you think it should be the follow-up for these patients, symptomatic patients?
Amanda?
Well, I would advocate for at least following their labs, if not every 3 to 4 months, at least every 6 months, because we do see that the patients, especially if they're somewhat symptomatic, can slide, especially with their hematologic manifestations. It can really progress rather rapidly. So if they're having symptoms, I would say at least every 6 months, bare minimum, to check labs to make sure you're keeping an eye on their hematologic parameters. But for the very stable patients, I'd like to have them get a 6-month set of labs, but we don't see them but like every year to monitor them overall.
Ignazio,
thank you.
Ignazio, yeah. Can I ask to Amanda a question that is related to this fantastic picture on T cells infiltrating the bone marrow? I think it's very important. Is it consistent in every patient, or you would suggest to make the staining and to decide about the treatment according to what you see? Do you see in all the patients that have this kind of hematologic involvement, how we can propose for everybody or a target treatment for a specific patient?
So in all the bone marrows, Dr. Kanakri and Dimitrova and I have reviewed in the patients who have the neutropenia specifically, we've overwhelmingly seen that there is that influx of the lymphocytes there. So specific to the neutropenia, we see that, but not necessarily do we see it in the pure red cell aplasia. So it's not overall the marrow dysfunction, but specific to the neutropenia. Okay. And I don't know if Drs. Kanakri and Dimitrova have any more to comment.
Yeah, what Dr. Umbrella said is correct. There's these aggregates of T cells, and then also a profound maturation arrest of the myeloid maturation that makes the marrow overall, and then sometimes also an eosinophilia that seems to come with that, although that also seems to sometimes precede it. And I don't know if it's related to the progression or separate, but it makes the marrow also more cellular and can even appear normocellular. But then when you look at the makeup of the marrow, it's this increase of T cells, and then again, the maturation arrest of the myeloid progenitors.
Very interesting. Thank you very much.
Thank you very much. We are running out of time, so we are leaving the resume and highlights about las frecuencias. I'm turning on in Spanish for the audience, sorry. La frecuencia estimada que tal vez en nuestra región haya subdiagnóstico. Así que los alentamos a pensar un poco más en esta enfermedad y a consultar, a ver opciones de derivaciones de muestra para diagnóstico. Que la enfermedad, como bien se explicó, se relaciona con un defecto genético que se asocia con un síndrome autoinflamatorio donde hay un predominio de activación de linfocitos de macrófagos M1 con compromiso variable del sistema inmune y hematopoyético, que tiene una presentación fenotípica muy heterogénea, así que hay que pensar un poco más en la enfermedad, y que el tratamiento de inicio es anti-TNF para los casos con vasculitis y síndromes autoinflamatorios, sobre todo en la prevención de stroke, en lo cual, como dijo Amanda, sería ideal en casos asintomáticos también, y considerar trasplante de médula ósea, células progenitoras hematopoyésicas en casos de compromiso inmunohematológico severo, y está en marcha la terapia génica, lo cual le queremos pasar a Chip para el cierre. Chip Chambers, por favor. Chip, thank you very much for supporting and maybe the future perspective of the disease.
Well, thank you, Ignacio. And I have to say first, thank you, and thank you. And thanks to Liliana and, you know, the LASID. This is what I talked about in my talk, collaboration. And this is collaboration squared. And all of these doctors that presented are also dear friends of mine, and they've spoken at all of the DADA2 conferences. But guess what? We even have more speakers at the DADA2 conference. And so we really want to invite all of our Latin American colleagues. Email me at chip.chambers@dada2.org for future conferences. Also, we are putting on this patient conference in May. Many of the doctors that spoke today will be speaking at that conference. You heard a lot of what ifs during all of this and maybes, and you know, we need to look further. And so currently the foundation has pulled together a group, many of these are on the presentation panel today, to work on a consensus paper, to really get down and struggle with some of these key issues. You know, how you know, I heard it in Ignacio's summary, you know, how long should you follow them? Should you do a liver biopsy pre-transplant? We really need to get this out in the literature, and while it may change in a year or two, we really need to provide some guidance for folks out there, because you're going to start seeing more of these patients. I published a paper with Dr. Lee and a group at MIT and the Broad Institute that will be coming out in the next several weeks, where we did some work on really calculating the carrier frequency and the prevalence of the disease. So I will divulge that information pre-publication. We believe that the carrier frequency is high as 1 in 225 people, and that the prevalence is high as 1 in 220,000, which is about, you know, 7.6 billion people. That's about 40,000 cases a year. Remember that cystic fibrosis, there are only 70,000 cases a year. And so as we define and see more mutations beyond the 200, that will improve the prevalence, meaning making it more prevalent. The other thing we're working on in the foundation is we're planning to pull a group of researchers together that have actively studied disease or want to study the disease to really grapple mechanistically. You heard Isabel beautifully talk about all these mechanisms. Well, how do they fit together, or do they fit together? Or what do we need to throw out? So we're looking forward to that as well. And then finally, you know, is the collaborative efforts like this. So please email me, get on our email list. I can't say it enough. And I just really thrilled with our Latin American community. We want you guys to be involved. I got a patient email the other day from Algeria and Libya. So we're expanding our physician network immensely, and we want our Latin American colleagues at the front of the line. So again, thank you. This is going to change some patient lives today, or future patients, I can guarantee it. So everybody have a great evening, afternoon, morning, everywhere you're hailing from today.
Thank you very much for being part and support and help. And the meeting is going to be posted in our network at the LASID page. So it's going to be up for future viewers. Thank you.
And we feel very happy. Thank you for your participation.
Gracias, muchas gracias por estar.
Muchas gracias.
Muchas gracias.
Adiós. Gracias.